Let's kick off. The subcommittee will come to order. The chair recognizes himself for an opening statement. I would like to welcome everyone to today's hearing. Today we'll hear for Mr. Daniel Sy, the Director of Center for Medicaid and CHIP Services, about some of the most pressing challenges facing the Medicaid program. Over 75 million Americans are covered by Medicaid, a number that approached nearly 100 million during the pandemic. According to Congressional Budget Office, federal spending on Medicaid is expected to increase from around $550 billion in fiscal year 2023 to almost $800 billion in 2033. And that does not include state spending. Continued unchecked growth in the program will inevitably lead to decreased spending on other important priorities, such as education or increases in taxes at the state and federal level. During an oversight and investigation subcommittee hearing 2 weeks ago, we heard about the increases in improper payments and the risks they pose to the program, which totaled more than $50 billion last fiscal year. In the hearing, we heard from the Department of Health and Human Services Inspector General, who stated there is a compelling need to prioritize program integrity to protect against improper payments. As a former state legislator, I know the work it takes to ensure Medicaid beneficiaries maintain access to high-quality health care services while maintaining vigilance over the program. Part of that work is engaging with CMS to approve state plan amendments in 1115 waivers or 1115 waivers in a timely manner so that states can administer the program. However, according to the National Association of Medicaid Directors in a recent Health Affairs article, CMS has taken more than 15 months to approve new waivers, which is a breach in the state and federal relationship in running this program. Yet instead of addressing these backlogs and working to ensure that the program is better managed, CMS has chosen to impose new sweeping regulations on states that will lead to increased spending and a decrease in services to beneficiaries. I'm extremely concerned about two of these rules, in particular, the nursing home minimum staffing rule and the Medicaid access rule, both of which threaten access to long-term care services for Medicaid beneficiaries by setting arbitrary staffing and pay standards. While I agree that we need to do more to ensure our frontline caregivers and clinical care providers are compensated commensurately with the care they're providing and offer a better quality of life for our most vulnerable, this approach simply won't work. These rules come at a time when we have seen more than 500 nursing home facilities close since the start of the pandemic, and where we have 150,000 fewer long-term care workers than we did before 2020. That is further evidenced by a collection of red and blue states suggesting in their comment letter to CMS that the rule, quote, threatens to make these critical programs so expensive that states will need to seriously consider controlling costs by serving fewer people, growing more slowly, providing fewer services, or cutting back on other aspects of the Medicaid program, end quote. This echoes concerns I have raised with these concerns alongside my Energy and Commerce Republican colleagues in a letter to CMS in September opposing the access rule. Today we're preparing to act by considering Representative Pence's bill, H.R. 7513, which would block the minimum staffing rule, and Representative Kamick's legislation, H.R. 8114, to block the access rule's 80% pass-through policy. I'll note that Representative Pence's bill already advanced out of the Ways and Means Committee with a bipartisan vote, and hope we'll see similar bipartisanship on these issues here. Of course, the subcommittee is not just reacting to the administration's flurry of bad regulations, but we're also being proactive in finding constructive solutions. Today's hearing includes a number of bipartisan bills to support long-term care and reduce program integrity for the Medicaid program. In particular, I would ask that my colleagues work with me on passing my bill, H.R. 468, the Building America Healthcare Workforce Act. This legislation will permit temporary nurse aides to work and support while nursing home residents while they work to become certified nursing assistants, filling a critical shortage in the workforce. This is a balanced approach that won't put new burdens on nursing home facilities like the minimum staffing rule, while also protecting our nation's seniors. Thanks to our witness for being here. We appreciate your time, and to my colleagues for their leadership on the bills before us today. I yield back and recognize the ranking member, the gentlelady from California, for 5 minutes for her opening statement.
Thank you, Mr. Chairman, and good morning, colleagues. Today, on the last day of Care Workers Recognition Month, we're going to discuss 19 proposals to improve Medicaid home and community-based services and ensure funding for Medicaid is well spent. Medicaid is the largest payer of long-term support services in our country, providing health coverage to more than, as the chairman said, more than 77 million low-income adults, children, parents, and individuals with disabilities nationwide. The American Rescue Plan Act, which Democrats passed in March 2021 without a single Republican vote, increased funding for Medicaid HCBS by over $37 billion. Every state, every single state, took advantage of this funding to retain, expand, and train direct care workers who are the backbone of our long-term care workforce. We have to continue to build on that progress. President Biden recently said that, quote, if we want the best economy in the world, we have to have the best caregiving economy in the world. Several of the proposals before us today, I think, get us closer to that goal. The Money Follows the Person Permanency Act of 2024, introduced by Representatives Dingell and Balderson, makes permanent the Money Follows the Person demonstration. It's a critical program to provide enhanced federal funds to states to help seniors and people with disabilities move from institutions to the community. The Stop Unfair Medicaid Recoveries Act, introduced by Representative Schakowsky, and the Protecting Married Seniors from Impoverishment Act of 2024, introduced by Reps. Dingell and James, end the outdated systems that keep Medicaid beneficiaries who need long-term care and their families in poverty. Representative Schakowsky's legislation stops states from going after families' homes for repayment of Medicaid long-term services. Again, Reps. Dingell and James' legislation protects spouses from having to deplete their financial resources to qualify for Medicaid coverage for long-term care. Some of the bills being considered today are partisan and would roll back recent progress to improve the quality of long-term care. For example, the Biden administration recently finalized a solution to the lack of staff providing care in nursing homes. Hire more staff. The new rule requires a registered nurse to be on site 24 hours a day, 7 days a week, instead of the current minimum of 8 straight hours a day. The rule also requires nursing homes to have enough nurses and nursing assistants to be able to give each resident at least 3.5 hours of care per day. I don't know about all of you, but I think if I were in a nursing home, I would want those standards. These requirements phase in for most facilities over 3 years, but give rural facilities 5 years to come into compliance. It also provides $75 million in grants to train nurse aides. The Protecting America's Senior Access to Care Act by Representative Fishback and Pence prohibits this policy, and it stops any similar rule from ever going into effect. The Biden administration also recently required at least 80% of home and community-based payments to go directly to care worker pay. This will help raise the pay for the home health workers our loved ones rely on. H.R. 8114 by Rep. Kamek prohibits this policy and stops any similar rule from ever going into effect. I support the administration's recent rulemaking to improve nursing home quality and raise the wages of care workers and oppose both of the aforementioned bills. Today's hearing is about the hardest questions a family can face. How do we take care of a family member at home? If that's not possible, can we trust a nursing home? How are we going to afford this care? I hope we can work together to find solutions to make the answers to those questions a little easier. And with that, Mr. Chairman, I yield back.
Thank you. The gentlelady yields back, and I now recognize the chair of the full committee, Chair Rogers, for 5 minutes for an opening statement.
Good morning, everyone. Thank you, Mr. Chairman. Many in this committee are familiar with my son Cole and his story. For those unfamiliar, Cole was born with Down syndrome, and just yesterday we celebrated his 17th birthday. Over the past 17 years, I've had the privilege of meeting with countless families with kids just like Cole, and they all want the same thing: for their kids to have every chance in this world to succeed and live up to their God-given potential. I've dedicated much of my career here in Congress to being an advocate for people with disabilities. We're all a product of our experiences, and that's why I'm grateful for today's hearing, where we will discuss solutions to support access to long-term care for people with disabilities. The Medicaid program was designed as an important safety net for those who truly need assistance and otherwise might not get the vital care that they deserve. Unfortunately, Medicaid doesn't always live up to this mission. States have wait lists for home and community-based services, key long-term care services to empower people with disabilities to live independently in their communities, allowing them to reach their full potential. I've met with too many people over the years who have struggled to get off these wait lists, or who have been afraid to pursue jobs out of state and risk being moved to the back of a new state's wait list. So I'm pleased that we are discussing potential solutions to start making sure Medicaid is best serving those who need it most. For example, my bipartisan legislation with Ranking Member Pallone will increase flexibility for states to offer more care by reducing these wait lists and making sure each state is tracking and reporting wait list statistics uniformly. We'll also discuss bipartisan legislation from Representatives Kiggins and Capter that would ensure coverage of home and community-based services for Medicaid-eligible dependents of active-duty military families. As co-chair of the Military Families Caucus, I'm proud to support this legislation, which would mean individuals won't lose coverage when their families move for a new assignment. There's over a dozen other important pieces of legislation that will be discussed today. We're working closely with the ranking member and his team on these bills, the majority of which are bipartisan. And I recognize that not all of them are perfect in their current form. For example, I have concerns with H.R. 8115 and how it would upend the shared state-federal partnership of the Medicaid program. It's important, though, that we discuss and debate the merits of each bill today through regular order and continue to work in a bipartisan manner to find solutions that we can agree on. And today we get the chance to do that. Unfortunately, while we continue to develop bipartisan legislative solutions, the Biden administration is making it more difficult in some instances for people with disabilities to access care. By setting unattainable staffing requirements, I fear that the minimum staffing rule will force nursing homes to close or reduce the number of seniors served. And the Medicaid access rule, so-called 80-20 policy, will lead to home care agencies reducing the amount of care that they can provide. Lastly, the recently finalized Medicaid eligibility and enrollment rule is estimated by CMS's own actuary to increase federal spending by tens of billions of dollars over the next 5 years, all without Congress taking a single vote on any of the policies and in the face of widespread opposition from disability advocates and states. In contrast, today, we will begin reasserting our role, Congress's Article 1 authority, by taking back control of the policy-making process. We'll consider legislation from Mr. Pence and Ms. Kamek that repeal these rules and hopefully avoid the negative consequences that I've already mentioned. This hearing is a great example of Energy and Commerce plowing the hard ground necessary to legislate with proposals to make sure that the Medicaid program is working as intended. And as I mentioned, many of these have bipartisan support. I look forward to today's hearing and continuing to work together to advance these solutions so important to the people that we serve. I yield back.
The chair yields back, and I now recognize the ranking member of the full committee, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Our nation faces an ongoing long-term care crisis that is impacting millions of American seniors, people with disabilities, and chronic conditions. and the growing need for long-term care continues to be one of the greatest threats to retirement security for American seniors and the adult children who care for them. Today, Medicaid is the nation's primary payer for long-term care services, but significant reform is needed to support a sustainable system. I've also long believed that we must move forward with bold solutions within both Medicaid and Medicare. This has been a priority of mine for years, and it's particularly important since demand for long-term care is expected to increase substantially as our nation's population ages. And this committee has long worked to expand access to long-term care for people who need it, while also improving the quality of care and promoting better pay for providers. We're continuing some of that work today by considering the Stop Unfair Medicaid Recoveries Act, bills to make the money follow the person demonstration program, and spousal impoverishment protections permanent, and bills to improve access to Medicaid home and community-based services for some of the many additional Americans who need it. And while I appreciate the modest improvements these policies would make, much more significant long-term care reform is needed. Last Congress, I was proud to co-sponsor the Better Care, Better Jobs Act, which would have increased funding for Medicaid home and community-based services, ensured those funds were used to improve the quality and availability of such services, and strengthen the direct care workforce by addressing insufficient payment rates and high turnover rates. And I've also previously released a proposal to establish a long-term care benefit in the Medicare program so that millions of seniors and people with disabilities no longer have to face financial ruin before they get assistance. And these are the types of sweeping reforms that we need to be thinking about in order to address the long-term care crisis. Unfortunately, we will not be considering proposals to make those types of changes today. Instead, we will consider several Republican bills that would worsen access to quality long-term care for the millions of Americans who depend on it. Some of the Republican bills that we'll consider today go after the rules the Biden administration just finalized last week that lay the groundwork for necessary systematic long-term care reform. The administration's action establishes minimum staffing standards for nursing homes, requires that at least 80% of Medicaid payments for home care services go to caregiver pay, and expands nursing home oversight. These are important steps, but Republicans have proposed bills that would prevent them from taking effect and would ban any similar initiatives in the future. We'll also consider Republican legislation to roll back protections that ensure nurse aides working in nursing homes meet minimum training requirements and that their training is provided in settings that meet minimum quality standards. Now, if we want to improve the quality of long-term care, we need to ensure there are enough qualified workers, and to ensure there are enough qualified workers, we have to pay them adequately and provide a safe place for them to work. And these rules by the Biden administration take steps to do just that. They also balance the unique challenges that some nursing homes and home and community-based service providers may face by phasing in certain requirements over time and allowing hardship exemptions where they're truly needed. And while I have concerns about these Republican bills that would undermine the Medicaid program, I'm pleased we will consider several proposals aimed at improving its integrity. To promote program integrity, we must acknowledge the system through which most Medicaid beneficiaries receive their care. More than 80% of Medicaid enrollees are covered by managed care programs, and increasingly states are turning to managed care plans to administer Medicaid long-term services and supports. The HHS Office of the Inspector General and the Government Accountability Office have long raised concerns about instances of waste, fraud, and abuse, low quality of care, and poor access to care in Medicaid managed care. Yet the federal government lacks practical means to ensure plan compliance with federal rules. So H.R. 8115 would give the government basic and necessary tools for Medicaid managed care oversight and enforcement, and there's no reason this legislation should not garner strong bipartisan support. So I know, Mr. Chairman, we have a lot to discuss today. Some of the bills are definitely, positive and bipartisan. Others are not, and efforts to roll back good things from the Biden administration. But this is certainly an important hearing, and I certainly am pleased that we're having it today. Thank you, Mr. Chairman. I yield back.
Thank you. The gentleman yields back, and now it's time to, let's conclude members' opening statements and move into our witness statement. So today our witness is Mr. Daniel Tsai, the Deputy Administrator and Director of the Center for Medicaid and CHIP Services. So Mr. Tsai, you said you testified before, you know the light system, after 4 minutes you'll have a yellow light, and if you see red, it's time to wrap up. We appreciate you for being here, and Mr. Tsai, you're now recognized for 5 minutes for your opening statement.
Thank you to the chair. Good morning, Chairs Rogers and Guthrie, ranking members Pallone and Eshu, and members of the subcommittee. Good morning. Thank you for the opportunity to testify before you about what we at CMS are doing to administer, protect, and strengthen the Medicaid program. Medicaid and the Children's Health Insurance Program provides access to critical healthcare services to more than 1 in 4 Americans. We cover almost half of kids in this country. We're the largest payer for home and community-based services, or HCBS services, as well as nursing home care. We're the largest payer for mental health and substance use disorder treatment. Our goal for Medicaid is simple. We want to make sure all eligible kids and adults are covered with as little red tape as possible. We want to make sure people can access critical healthcare services in a timely way, in such a manner that any of us would find acceptable. We want to improve health outcomes and the cost effectiveness of care, and we want to ensure strong program integrity. Let me first spend a minute outlining what we're doing to strengthen HCBS, which we just heard some very important comments on. First, I want to thank Congress for making really important investments in this area. HCBS services are critical, as you know, to helping to be able to continue living at home or in the community for people's independence and dignity. This includes children with medically complex conditions or intellectual and developmental disabilities, adults with disabilities, and older adults who need supports to be able to age in place. This administration's goal is to make sure Medicaid enrollees who need HCBS services receive them timely and with high quality. The president's budget calls for a $150 billion investment or down payment to further strengthen HCBS, and we hope to work with Congress on these critical investments. And as you know, we recently finalized a historic rule for Medicaid access, which, among other things, enacts a systematic and multifaceted set of changes to strengthen home and community-based services. For example, we emphasize the need for states to pay sufficient rates to home care and HCBS providers, and we require transparency into what states are paying HCBS providers in a way that we've never had before. And at the same time, as this committee just noted, we require that at least 80% of Medicaid HCBS rates go to direct care workers and not to administrative overhead or profit. We also require states to measure timeliness of access to HCBS services. For example, how long does it take for someone who needs home care to actually receive those services? And we require states to track how long wait lists are for HCBS. And for the first time, we establish a consistent set of quality measures for HCBS across the country. I'd like to turn briefly now to our efforts at CMS on strong program integrity for the Medicaid program. We and our staff take our responsibility for oversight and fiscal stewardship incredibly seriously, and states, healthcare providers, and managed care plans have certainly been feeling this intensity of focus. I know I hear about it all the time from our stakeholders. First, we have taken significant steps to strengthen program integrity in Medicaid managed care plans, including through our recently finalized managed care rule. For example, we established maximum appointment wait time standards to make sure managed care plans are delivering services to their enrollees. You've heard much about state-directed payments. We strengthened federal standards for these supplemental payments, including requiring that states and managed care plans report actual spending on these payments to CMS. And beyond the rule, we've also increased our audits and reviews of managed care plans, and we've taken firm action. We're also committed to continuing to measure and reduce the rate of improper payments across state Medicaid programs. It's important to note that the vast majority of improper payments result from clerical or documentation errors by a state or provider for covered services delivered to eligible people. However, any level of improper payment is unacceptable, full stop. And we have substantively engaged with states to take necessary steps to remedy and therefore reduce improper payments. We're committed to continuing to build a stronger Medicaid program, and we look forward to continuing to work with Congress to advance this goal. Thank you for the opportunity to testify, and I look forward to dialogue with this committee.
Thank you. That concludes the opening statements, and we will now begin questions. And I will recognize myself for 5 minutes for questions. So, Mr. Sy, your agency also appears to be finalizing a rule for May 2023 that will require manufacturers participating in the Medicaid drug rebate program to stack or add up all the rebates they offer in the entire channel to determine their best price. And this is in direct contrast to 30 years of precedent and clear legal reading of the statute that says the best price is the single lowest price a manufacturer gives. Can you share what steps HHS has taken to determine how manufacturers and others in the supply chain can even comply with this rule, as well as steps you've taken to protect patient information?
Thank you, Mr. Chairman. Appreciate that question. We want to make sure Medicaid enrollees have access to life-saving medication, and we want to make sure, as fiscal stewards, we are paying an effective rate and making sure that we're implementing the full effect of the Medicaid drug rebate program, as you're well aware of. And so, as you noted, we proposed a rule on a range of things for ensuring there is access to drugs in the Medicaid program. On the stacking provision that you referenced, we certainly heard many comments.
So I only got a couple more questions. I understand that what you're talking about, and absolutely, having been at state level and here, want to pay the lowest price as well. But you want to pay a price that's going to guarantee the access to the drug. Have you looked at the price being so low that manufacturers won't supply the drug to the Medicaid program?
So,
Are you concerned about that?
we want to make sure people have access to drugs and that we're being good fiscal
But are
stewards.
you concerned that the stacking price may get so low that they won't have access?
As you know, we're in notice and comment rulemaking. I can assure you, we are thoroughly considering, I would say, the voluminous set of comments we've received on this provision.
Okay, let me move on. So I just went through, unfortunately, a family situation trying to find long-term care, and it is incredibly expensive and set many times going, how does the average families deal with this? And one of the big problems is labor, and so now you're going to increase the cost of labor, and you see the nursing homes would say, or the care homes, that they're having to increase labor without any reimbursement costs coming forward, so they're kind of being pinched, and so it's pushed off to the private sector moving forward. So I have a provision to try to increase the access to good labor, because that's what we want. And it was from a waiver from COVID about allowing, so it's a pandemic over waiver. And before, and I'll tell you what it is, but before I decided to offer the bill, I asked the question, were there any reports during the waiver of any negative incidents because of this program? And I received none. So we know we have a program that's safe, and I want to try to move this forward. And what it does, it allows temporary nurses, aides, to provide bedside care for as long as it takes them to reach 75 hours of training requirements to become a certified nurse assistant. And we believe this is the right approach to create a pipeline moving forward. And since we had a waiver and it was successful, there's no incidences that we know of, so it's safe. Would you support my legislation or a similar framework to commit working with us to get this signed into law?
Thank you for that, and I'm sorry to hear about your recent experiences, and thank you for your focus on making sure there is sufficient access to workforce in long-term care settings. As you know, I can't comment on any specific legislation, but we deeply support making sure there's sufficient access to all sorts of long-term care, and also that we are considering a range of creative solutions to think about how to make sure we can address the pressing workforce challenges, and so we'd be happy to work on anything as helpful.
Yeah, I didn't know you couldn't comment on legislation, but okay. I think you're going to comment on some later, so we'll see where we go with that. On the access rule, it's going to force states to control costs, and we think provide fewer of these services to smaller number of patients. So my concern is that we want a safe place for people to go. We absolutely want that. But we're worried about we're getting to a point where people are going to leave the marketplace, or it's going to be so expensive people can't provide. And we just want to comment, can you guarantee that your rule won't lead to patients getting less access?
So I assume from the access rule you were talking about the
access rule, the 80-20.
For on home care. So we want to make sure people have access to home care and that it's quality. And we know that staffing is, as you've noted,
It is a big problem.
It's both a challenge and it's critical to making sure there's quality care that can be delivered. And that's really
Do you think this particular provision would hurt access?
It affirms that people can have access to quality care because the workforce is critical, and we received a tremendous amount of comments on this, as you're indicating, and the rule we finalized is substantively different from what we proposed to account for longer timeframes, to create exceptions for, say, small providers or rural providers and the like. And we also emphasize that states have an obligation to pay a sufficient rate for home care and HCBS services.
Thanks. Well, my time has expired, and I will yield back and recognize the gentlelady from California for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you very much, Mr. Tsai, for being here with us. You have an incredibly important portfolio that you oversee. 1 in 4 Americans in your care. On April 22nd, as we all know, the administration finalized the policy to require states to spend 80% of Medicaid payments for home care services on compensation for workers. I'm glad the administration has taken the steps that they've taken. There are many groups that support the policy. Opponents of the policy argue that 20% of payments isn't enough to cover administrative costs. So I want to give you the opportunity to tell us why you chose this approach to improve the HCBS workforce. Why is the 80-20 proposal so important? And what do you have to say to the opponents?
Thank you to the ranking member for that question and your support for home care HCBS services. We, as part of making sure people can have access to quality care, we need to make sure that there is a sufficient workforce available, which requires a sufficient funding for the workforce. And importantly, for one of the reasons why we finalized this rule is to make sure that Medicaid payments for direct care, for home and community-based services, should go to direct care workers versus administrative overhead and profit. And we did have very clear data points that pointed us to the 80%. And in addition, the American Rescue Plan, which I thank Congress for as well, and those investments, that $37 billion, the vast majority of states that, every state utilized that funding, the vast majority, almost to a T, used that on workforce, and many of them, as they made investments in workforce, also had requirements that a sufficient portion of those investments would go to the direct care workforce. So we are seeing that, that interest and appetite and policy direction from states across the continuum as well.
I would note that the Republican Study Committee, which my understanding is they represent a majority of the Republican conference, released its budget for fiscal year / That budget endorses gutting funding for federal health care programs by $4.5 trillion, including the Affordable Care Act, the Children's Health Insurance Program, and of course, Medicaid. What would that do? What would the ground look like if that were to be the case? And what is the president propose in his budget to strengthen Medicaid?
Appreciate that question, and I haven't seen the study committee's report, so I can't comment on that. But relative to the impact of any large budget cuts for the Medicaid and Children's Health Insurance Program, it would be devastating for the health and mortality and morbidity for kids, adults, individuals with disabilities, others all across the country.
Yeah, we're not talking about systems that are rich systems to begin with, and I think that it's very important to have balanced policies. We can't afford to do without nursing homes in our country. In rural areas, the stress is even greater. But I don't think we're going to attract and keep a workforce unless they can live on what they make. And so in your considerations, did you have like 10 or 20 options that you examined and then landed on this one, taking all of these things into consideration? Because there's a real bone of contention here, obviously. Could hear it in the chairman's opening statement and then in mine and the others.
I appreciate that. I would say one really important thing to emphasize is in part of supporting stronger access to home and community-based services, the rule hit on many different pieces. The 80-20 was only one piece. There were many other provisions, from quality to transparency of rates to wait lists, which Chair Rogers discussed. And so it is a multifaceted, systematic way of getting at how do we make home care stronger and more accessible. And we also think that investments are really important down payments. And you asked about the president's commitment. The president's budget includes proposal for $150 billion investment into home and community-based services.
Well, my time has expired, and I thank you for being here today and the such important work that you do day in and day out. Yield back, Mr. Chairman.
Thank you. The gentlelady yields back, and the chair will now recognize the chairman of the Rules Committee, Chair Burgess, for 5 minutes for questions.
Thank you, Chair Guthrie. Thanks for being with us here today. In your written testimony, one of the footnotes deals with the amount of improper payments. And although you don't list it out specifically in your testimony, the improper payment rate for Medicaid for an aggregate of years, 23, 22, 21, is listed as 8.5%. One of those years, it was as high as 15%, the improper payment rate. And let me stipulate, improper payment rate is not fraud, but improper payment is money that was paid that possibly was not correct. Just as a point of reference, do we know what the improper payment rate for Visa and MasterCard is?
I appreciate that question. We take our fiscal responsibility very seriously, and we want to make sure that we are reducing that rate of improper payments.
Well, and I want you to take it seriously. $50 billion is a figure that's given in your footnoted report. I'm also on the Budget Committee. You know the massive amount of deficit that this country is running right now. Interest rates have been jacked up the last 3 years. So that $50 billion costs, there's a lot of carrying costs in that $50 billion. It's not just that we spent $50 billion more than we should have based on the bills that came in, but now we've got to do the debt service on that $50 billion. And with the size of your agency and the size of the federal government, you begin to get an idea of how that can snowball and why it's so important that we stay focused on it. Still, at the same time, I'm concerned that it does seem that the scrutiny placed upon a state like Texas, a state like Florida, may be higher than what you would expect from other states. And in fact, there was a newspaper article that openly suggested Florida, because it may be producing a political rival to the president, Florida came under increased scrutiny during that time. Can you comment to that?
So I appreciate the question. I just want to first agree wholeheartedly. Fiscal integrity, reducing the rate of improper payments, making sure that every Medicaid dollar, both federal dollars and state dollars, are wisely and prudently spent, because we've just talked about how many priorities there are, how much there is to make sure there's investment in. We couldn't agree more. We're very focused on that. And in fact, in our discussions with states, I think we were so focused on it that in every discussion we have around X or Y, states are raising to us, how are you auditing us? What's going to be the impact on your improper payment reviews? And so I think that increased scrutiny and that strong, firm approach we're taking is having an effect. And our goal is to make sure that there are as few improper payments in the Medicaid program as possible.
So no one wants to see improper payments. At the same time, there is also a cost to not spending money that you perhaps should have spent. And one of the things that has concerned me greatly over the last 3 or 4 years, it now has been corrected. Texas, as of the 1st of March of this year, is now covering postpartum care, post-delivery care for a full year rather than 2 months, which had been the standard in Medicaid. It took a while to get that done. One of the interim steps was Texas agreed to cover 6 months of care after delivery in the previous legislative session, but you all stopped that. And water under the bridge, and you can't go back and redo that, and now the problem is at least in theory solved. But why would you make a decision like that? The state is meeting you halfway, coming halfway to where you want. Why would you deny them for that, recognizing they've got a 2-year legislative session? Why would you do that?
I appreciate that, and we, I think, share a common goal of wanting to make sure that there is as much postpartum coverage, the 12-month option that Congress put forward, as possible. And I would note we have 46 states plus territories that have now taken that 12-month postpartum option, the state plan option outlined by statute by Congress. Thank you all for that authority.
You're welcome. And the option was, I thought, important because some states, like Texas, react differently if you tell them it's something they have to do, and then their court case is filed and you actually delay getting the good policy in effect. But again, I don't understand why the agency itself held that up. The 2 years where it could have been 6 months of coverage, I don't know what number to put on that as to the number of lives that could have been saved, but it seemed meaningless and it seemed arbitrary and it seemed capricious, and I wish you wouldn't do stuff like that.
Appreciate that.
Mr. Chairman, I'll yield back.
Chair yields back, and the chair will now recognize Mr. Sarbanes for 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Mr. Tsai. As you know, millions of Americans rely on Medicaid for health care services ranging from preventive and primary to specialty and long-term care. Of these individuals, more than 80% now are enrolled in Medicaid managed care plans, making it critical that these plans provide comprehensive coverage in compliance with existing law. Unfortunately, CMS does not have the tools to fully and effectively ensure this compliance. For example, last year, the IG found that Medicaid managed care plans may have inappropriately delayed or denied care for thousands of beneficiaries, ranging from cancer patients to individuals with disabilities in need of long-term care services. And state oversight of this issue was limited, likely allowing inappropriate denials to go undetected. Earlier this year, the IG found that as our nation is facing an acute mental and behavioral health crisis, some states' Medicaid managed care plans do not meet federal parity requirements. Would you agree that this is troubling and merits a look at how we can strengthen federal oversight to make sure no patient is wrongly denied coverage for care?
I appreciate that question. As you noted, managed care is a significant portion of the program today across states, and our firm commitment and belief is that we oversee and are working to ensure firm and strong program integrity within managed care plans, which, as you noted, a core piece of that is making sure that managed care plans can deliver care in a timely way to people that are enrolled without undue burden. Our recently finalized managed care rule puts a substantial number of additional transparency and accountability measures, including, as I noted, measuring appointment wait time of how long it takes to get services within managed care.
Under current law, CMS lacks effective mechanisms to ensure compliance in many instances, notwithstanding what you just said, because it can only defer or disallow its entire capitation payment to a state. As you know, this is effectively a nuclear option for enforcement, and one that, if used, could have serious implications for beneficiaries' continued access to care. Can you talk about the challenges this presents for CMS's oversight and enforcement capabilities, in particular, obviously, for the Medicaid managed care arena?
I'm really glad you raised that. Thank you. It's as part of, as the entity overseeing Medicaid managed care, part of that, it's critical to have the right tools to be able to do so. And as you noted, current statute, unlike for the rest of the non-managed care program, I think you used the word nuclear option, but right now there is only the option if we identify an issue, a compliance issue with the managed care plan, the only option we have is to disallow, say, the entire payment for that month to managed care, which in a state, if it's a state that has largely managed care, that's effectively shutting off federal dollars for the Medicaid program for that entire month. That is a very difficult option. It does not allow us, therefore, to effectively take action if we find smaller compliance issues, which we would want to remedy, but we have no recourse except to do all or nothing.
Can you talk a little bit about what you try to do in spite of this gap to promote compliance in Medicaid managed care? I mean, I've introduced legislation, the Meaningful Oversight of Medicaid Managed Care Act, that would give CMS the authority that you're seeking, which is to issue partial deferrals or disallowances to help hold states and managed care organizations accountable and improve patient care without threatening beneficiary access to care. So we're trying to help you here with the toolkit that you described. But tell me what you're trying to do in spite of this challenge you currently have, as we're trying to get the cavalry there to help you out.
I appreciate that, thank you. Yes, we are using every available tool to us at the moment to have strong programmatic oversight of managed care plans. As I noted, we just finalized a comprehensive rule on managed care last week. That rule includes many strengthened provisions. For example, transparency on how certain dollars are spent within the managed care program that we did not previously have. I've mentioned appointment wait times a few times. How hard is it to get services within managed care plans, and including measurements of how to make sure that sufficient dollars are spent on medical care versus other types of care. Those are all pieces. And finally, I'd add our team and our colleagues at CMS, and also with our colleagues at the OIG and GAO, there are a regular, frequent number of direct audits on managed care plans to make sure that managed care plans are fulfilling their obligations under federal requirements.
Well, I'm out of time, but hopefully we can get you some new tools. Thank you,
Appreciate
Mr.
that.
Chairman.
Thank you. The gentleman yields back. The chair recognizes Mr. Latta for 5 minutes for
Well,
questions.
thank you very much, Mr. Chairman. Healthcare costs have drastically risen, and it is imperative we prioritize who was originally intended for Medicaid, low-income seniors, children, individuals with disabilities. Proper oversight is needed to prevent those from gaming our system and stealing resources from those who rely on them. Mr. Tsai, CMS recently finalized a new eligibility regulation. The new regulation says that when conducting an eligibility determination, a state has to give an individual an initial 30 days to respond to a request from the state verifying their eligibility. From there, the individual can be entitled up to 90 additional days before a final determination on coverage is made. In short, someone who's ineligible for Medicaid but attempts to dispute that decision can get Medicaid coverage for up to 4 additional months. Just out of curiosity, do you know how much that costs the states?
So I appreciate that question. I'd say our goal is to make sure eligible people are able to smoothly enroll into the program or renew without enormous amounts of red tape, and that ineligible people are successfully transitioned or can get coverage through other
But
sources.
do you have some kind of numbers as to what that would be for those that were on that for that 120 days that shouldn't have been on it, what it might be costing the states?
So as part of,
If you don't have that right in front of you, if you get that for us, we'd appreciate that.
we would be very happy to follow up.
Thank you. Last year, the improper payment rate was over $50 billion, following up from my friend from Texas in Medicaid. If Medicaid kept paying for someone who was ineligible for the program for this 4-month period, would that be considered an improper payment?
So as I've noted, we it's very important to us to make sure that states are following federal requirements on eligibility enrollment processes and that we're minimizing that improper payment rate.
But would that be an improper payment, or how would you classify that?
There are a whole range of rules that we have around what the eligibility process is for states, and our focus is to make sure that they follow all the required federal.
If also, if I could get those eligibility requirements, I'd appreciate that, see what would be considered an
follow up on that
improper
as well.
payment.
Thank you.
Thank you. Recently, the Biden administration finalized their mandatory staffing ratios for nursing homes. Portions of my district are extremely rural, and finding staff for certain jobs can be difficult, particularly in healthcare. Independent reports show that 80% of nursing homes cannot comply. Before I go into the question is this. I was a Wood County Commissioner for 6 years in Ohio. Our counties can have nursing homes. So the 3 commissioners in my home county, me being one, were in charge of a 120-bed nursing home. It's difficult to find people out there today, and Wood County is not what you consider rural. Also, the staffing is difficult because we're very, very fortunate in our jobs. We get to be able to go through a lot of different facilities, and not only facilities, but also nursing schools. And when I've gone through the nursing schools, one of the questions I always ask, pretty much a lot of the nurses, or the students that are about ready to graduate, what do you want to do when you graduate? You know what they tell me? About 80% want to be traveling nurses. And I say, what do you want to do that? And some say, well, you get paid more. So, you know, all of a sudden you're competing in a situation like that with just human nature where people want to go. So the other problem is that a lot of people look at rural areas and say, well, you know what, we're too far from what we want to be near, and all of a sudden we don't have people there. And I know, again, having been in that situation as a commissioner, now we had an administrator for the hospital, for the nursing home, but I'm very concerned about that because I think we have to think about that because, again, just out of curiosity, would you know at the Center for Medicaid and CHIP services, how many people have come from being administrators or working in nursing homes?
So, well, first, I appreciate your focus and push on how we as a country and in the Medicaid program.
Well, I only have a little bit of time left, but I'm just, if I'd like to get that information too, because I think it's very important, because if you're not in those shoes out there, it's very difficult to understand. So the question really becomes is how when people have to think about where they're going to have their loved ones at, especially with our seniors who might have to relocate from a nursing home because they won't be able to have the staffing at that one because they're going to say, because of the new guidelines, we can only have X number of people here, and unfortunately, we're going to have to triage some of these folks, and they're going to have to leave. So the question is that being considered? What happens to those people?
So I appreciate that. I mean, clearly, all of us agree, people need if a nursing home is right for an individual, we want to make sure someone can get access to that and that they can be assured that care in that setting will be safe. And a lot of the focus on staffing and workforce, there are certainly some significant staffing challenges that require a creative approach, but the evidence is clear that part of a safe level of clinical staffing, as you know from your former role, is ensuring there is enough staffing. And the rules really do that, including some very common sense pieces like a nursing facility, a nursing home should have a 24/7 registered nurse available in case your loved one has cardiac arrest at 2 a.m. You want to make sure there's the right staffing and supports available, and that's really what the rule focuses on.
Mr. Chairman, my time's expired, and I yield back.
The gentleman has yielded back, and the chair recognizes Mr. Cardenas of California for 5 minutes for questions.
Thank you, Chair Guthrie, and also I'd like to thank Ranking Member Eshoo for holding this hearing to discuss efforts to improve access to Medicaid services and program integrity all across our great nation. I'd also like to thank Deputy Director Tsai for joining us and sharing your expertise and details of your work administering, protecting, and strengthening Medicaid for all patients. As the nation's single largest payer for long-term care services, Medicaid plays a critical role in meeting the day-to-day needs of millions of Americans. I'm encouraged by the many bipartisan proposals discussed today that take necessary steps towards strengthening the integrity of the Medicaid program. However, I'm also concerned that certain proposals included in today's hearing seem to chip away at CMS's ability to support the long-term care services system and undermine workforce protections, which will take us in the wrong direction. And I believe that those workforce protections actually help the patients and the service rendered. In October of last year, we heard from long-term care service providers who were clear that recruiting and retaining their workforce has been a struggle. I'd also like to call attention to, once again, to the fact that in my home state of California, 60% of direct care workforce workers was estimated to be women of color. And at the national level, foreign-born workers make up about 25% of the direct care workers in the home care industry and 19% of direct care workers in the nursing home care industry. Despite the vital work this diverse and dedicated workforce performs, they continue to face low wages and high burnout. Mr. Tsai, your agency recently finalized rules aimed to supporting and stabilizing the direct care workforce. Can you explain how the finalized versions of the nursing home staffing rule and access rule considered the direct perspectives of long-term care stakeholders?
Thank you for your, for those comments, the question, the focus on making sure we have a sufficient, a well-trained workforce, direct care workforce to attract and retain across both home care and nursing home services. That is absolutely critical. The evidence is clear to making sure that people not only have access to services, but that's high quality and safe. And the multiple set of rules and policies you see us having recently rolled out, not just with the 80-20 and the staffing piece that we've discussed so far, but a whole suite of things, really aim to strengthen and emphasize that, including sufficient payment investments in the workforce to ensure that access is there for the people that need it.
Thank you. And your agency also shared a commitment to advancing health equity, expanding coverage, and improving health outcomes. Can you elaborate on how these workforce provisions advance health equity, ensure access to care, good quality care, and improve health outcomes?
Absolutely. We serve, we are the nation's largest payer, as you noted, for home care and home health services and long-term services and supports. But from an equity standpoint, there are folks that have resources that don't need our coverage and are able to access home care and other supports. We want to make sure that the people enrolled in the Medicaid program all across the country have equitable access and that it's culturally and linguistically competent. As you know, the direct care workforce, who that person is coming into your home, the relationship you have, those are critical pieces, and that's why it's important to have a well-supported, well-trained workforce.
And when it comes to quality care, you just mentioned that some people get their own private care. They could afford somebody to actually come to their home to take care of their aging grandmother or what have you. But we're talking about individuals who need Medicare to make sure that their loved ones get the quality care that they deserve. Should we have a two-tiered system, or should we constantly strive to make sure that our system provides the best care regardless of whether or not that family has the income to provide that private health assistance?
We wholeheartedly believe that people should be able to access quality care across the board in a way that any of us would expect for ourselves or our families, and that's exactly what the rules and the policies we roll out really seek to underscore.
No, we're talking about the kind of care that some people need 24/7, the kind of care that maybe the only caring human being that person comes into contact with is actually their caregiver or caregivers.
That is indeed sometimes the case, and we want to make sure that people have access to a strong set of supports, including home care, so that an individual can be as independent, say, age in place in their home. And if someone desires to be in a nursing home, we also want to make sure that the care is sufficient and safe in that setting as well.
Thank you. Mr. Chairman, my time has expired. I yield back.
Thank you. The gentleman yields back, and the chair recognizes Chair Rogers for 5 minutes for questions.
Mr. Tsai, I'd like to start off by asking you a question that Secretary Becerra couldn't answer for us a few weeks ago. Do you know how much the Office of Actuary expects that the recent Medicaid eligibility and enrollment rule will cost Medicaid over the next decade?
Thank you for that question. I think you were asking about both access and managed care. Across those, we want to make sure that we're able to ensure access and have strong oversight.
I'm asking
of
if you
managed
know
care
how much it's
programs.
going to cost.
The regulatory impact analyses are posted alongside every one of our rules and are publicly available for folks to take a look
So the
at.
answer is it's more than $50 billion. $50 billion in Medicaid in just the first 5 years. $38 billion paid by the federal government, $23 billion by the states. So you used to run the Medicaid program in Massachusetts. I can't help but wondering, how exactly is a state going to balance their budgets when incurring those kinds of costs? When regulations, so my question is, when regulations like this go through CMCS, do you consider whether states will need to cut reimbursement rates or services to offset cost, that your office is imposing on them?
So I appreciate that. Our obligation and our focus is to make sure that people enrolled in the program have strong access to care and program integrity, and we're able to oversee the program, ensure the right requirements are in place. The 2 rules that we finalized on the Medicaid side last week have a whole systematic suite of initiatives that support those things in tandem, and we work very closely with states on what the impact looks like and how to do it. And in fact, as a former state Medicaid director, this was very important to me. Some of the provisions that we outlined in the rules take effect over a multi-year period, precisely for the reason you mentioned.
So I'm going to reclaim my time and just underscore, we're talking billions of dollars, mandates that you're making without any elected representatives having a say in this, that's going to cost and in fact could actually limit access to care. That's what we're talking about. While I have considerable amount of concern with the recent Medicaid regulations that were finalized in the last 2 months, I do want to highlight an area of common interest that we share. The recent Medicaid access rule calls for increased transparency into the state of the home and community-based care waiting lists. So I just wanted you to speak, if you would share with the committee what you know about these lists, how many people are on them, what care they receive when they get off, and what we hope to learn from the new transparency requirements.
I appreciate that, and we very much share that same interest. We want to make sure people have access to home care services, and as you noted in your opening statement, there are many states across the country have wait lists for that. Unfortunately, we CMS do not have a consistent data set to understand what the wait list length is across states. Are those apples to apples comparisons, and therefore what are states doing to be able to reduce those wait lists? The regulations we finalized require that states report that to CMS in a consistent way that allows us to monitor and have discussions with states about that exact topic.
The last time I heard in Washington State, we're talking 15,000 people that are waiting. And I have a friend who would like to take a job in DC, but he can't. He won't do it because he'd be put on the back. He'd have to wait years
Sorry to
in
hear
this
that.
region. Mr. Tsai, a few weeks ago, our subcommittee on oversight and investigations held a hearing on improper payments in the Medicaid program. So they're at an all-time high, and we need to be doing more. GAO, OIG highlighted a number of concerns associated with inadequate beneficiary and provider screenings, where states are failing to do simple things like ensuring we aren't paying for deceased beneficiaries. GAO and OIG repeatedly urged CMS to increase its oversight of screening practices by the states. They noted mixed responses from CMS in regards to the agency's willingness to engage on these issues. And I understand things have been challenging for states and the Medicaid program over the last few years because of continuous coverage requirements and the current unwinding process that states are going through. But can you speak to what new work CMS is doing to better audit improper payments now that the unwinding process is coming to a close?
I appreciate that. I agree wholeheartedly that fiscal integrity, fiscal stewardship of the program is incredibly important, and also that improper payments, any level of improper payment is unacceptable. And that has been a huge focus of work for our team with states. I would note as one example of some of the new work, you noted deceased individuals with the managed care plans. We have very clear federal rules that say managed care plans cannot be paid their monthly premium for deceased individual around that. We wholeheartedly agree with the OIG and others around that point. We just put out additional reinforcement and guidance to states about exactly how to do that. And I would note states have a common interest here. We recoup the money from states. When we or a federal auditor or someone else audits and identifies an individual that was deceased where there's a managed care payment, and so states have every interest to take up the reinforced guidance that we have put out.
Look at this.
My understanding is that you still allow it up for a month for the payment to still continue. So anyway, we'll keep working on this. I yield back. Thank you
Thank
for
the
being here.
gentlelady for yielding back, and thank you for highlighting that excellent committee that hearing by the Oversight Committee. I hear the chair did a great job. Just saying. Now recognize Ranking Member Pullen for his 5 minutes of questioning.
Thank you, Mr. Chairman. Mr. Tsai, In your testimony, you spoke to the benefits that the American Rescue Plan Act had on beneficiaries' ability to access home and community-based services, and that law provided states with a temporary 10% point increase to the federal matching rate for Medicaid home and community-based services. So my question is, can you describe the types of initiatives states adopted with that temporary increase in Medicaid funding and the investments we could expect states to make if additional funding for home and community-based services was provided in the future?
Thank you for that, Ranking Member, and both you and Ranking Member Eshoo referenced that $37 billion American Rescue Plan investment in home and community-based services. I firmly believe that without that, we would have had a large and substantial number of our HCBS providers have to shut their doors as a result of real challenges through the pandemic and ongoing. Almost every state used that funding to strengthen the workforce, including things like retention bonuses, increased wages, training programs, and things of that sort, really with the affirmation that without a strong workforce and a well-compensated workforce, home care, nursing home care will not be able to compete with other sectors, with hospital care, and that's critical for us being able to ensure that our enrollees can access safe, high-quality care.
Well, I thank you. I'm concerned that many people who need home and community-based services are unable to access them at times, oftentimes waiting years to receive services. So let me get my second question. How would the Medicaid access rule that was finalized last week help CMS to better oversee Medicaid home and community-based services, and specifically how states manage waiting lists?
I appreciate that. Our team is quite excited about the many provisions in the rules that we finalized because, as you noted, there is a systematic approach required to making sure that access is available in a timely way. And it's not just one solution, it's multiple. And that includes what is the rate of payment to HCBS providers and is it sufficient? We require for the first time measuring wait lists. We also require for the first time measuring how long it takes to get access to HCBS services. Those are not facts any of us have today, and they are necessary and important to making sure that people can have access in a timely way.
Well, thanks again, and I appreciate the work that CMS has done to promote greater transparency in this area, and that's why legislation that Chair Rogers and I co-sponsored would codify and build upon requirements for states to report on home and community-based services waiting lists. I want to discuss another issue, the impact that the Medicaid unwinding is having on American families. Many states' eligibility and enrollment systems and processes have long been out of compliance with federal law, and as a result, Medicaid beneficiaries are being unfairly terminated from the program, and applicants are experiencing unlawful issues like long wait times before receiving an eligibility determination. So my question is, when will states be required to commit to specific plans for coming into compliance with longstanding eligibility and enrollment requirements, and how will CMS hold states accountable to those plans?
Thanks for that. And first, I have to thank you for your continued leadership and interest and perhaps persistent letters and focus on this topic. We agree. It's fundamentally important for us that everyone that is eligible be able to renew their Medicaid or Children's Health Insurance Program coverage as easily as possible without red tape. And as you noted, what we see from the data is that state choices matter, and whether or not a state adopted certain policies to reduce red tape fundamentally impacted what the results look like. On your question about when will states need to come into compliance, we are holding states accountable, I assure you, on following all federal requirements, both for existing rules and the recent rules for eligibility that lifted and strengthened those standards. We will be providing additional notice publicly shortly around some of the timeframes for compliance at the state level, and we look forward to continued dialogue with your office on that.
And I appreciate it. That's really important. I really support, or I should say I strongly support further action to ensure states commit to detailed, comprehensive plans for coming into compliance with these longstanding and critical beneficiary protections. And I would like those plans made public so that we can work together to ensure states adhere to them. So With that, thank you, Mr. Sy, and I yield back, Mr. Chairman.
Thank you. The gentleman yields back. The chair will recognize Mr. Griffith for 5 minutes for questions.
Thank you very much. Directed payments are one of the largest growing portions of Medicaid spending. These payments are important for many states, and I understand the need for them, but transparency is critical for the public, and policymakers have to have timely access to information on what payment arrangements have been approved and the effects of these arrangements on quality and access to care for Medicaid enrollees. Now, I know you touched on this in your opening, but the Centers for Medicaid and Medicare Services has already done a lot, but maybe we can do more because both the Government Accountability Office, GAO, and the Medicaid and Children's Health Insurance Program Payment and Access Commission, MACPAC, have recommended bringing more transparency into state-directed payments. My bill, H.R. 8113, the Transparency in State-Directed Payment Acts, does just that. Do you agree that this type of transparency would be helpful? And if so, why?
Appreciate that. Wouldn't be a Medicaid hearing without discussion about state-directed payments, so thank you for that question. For state-directed payments, we have two important goals. One, we want to make sure there's adequate funding for the safety net, for providers, and in fact, one of the most common pieces of outreach we have from congressional delegations is how important state-directed payments are to their particular state and providers. And at the same time, as you're noting, we want to make sure we have strong fiscal stewardship. Those state-directed payments, we have transparency, we have oversight, and we know that they're in conformance with federal requirements. And so we have similarly put out in the new rule more transparency requirements on state-directed payments. We think it's important, even if they're really critical, for everybody to have, as you noted, transparency into the levels of payments and how they're funded.
All right, I appreciate that. Are you aware of any directed payments being used by states to push hospital reimbursements to exceed 100% of costs for delivering care for Medicaid beneficiaries?
So as I noted, state-directed payments are critical for reimbursement, and we are making sure we have a lot of federal rules around what states need to do to comply with those, including various payment limits and the like. Part of the new rule that we put out, part of our oversight, includes asking every one of the states those exact sorts of questions and to make sure that all the payments are in compliance with individual rules.
Now, the chairwoman of the full committee brought up the oversight subcommittee hearing on overpayments, and we heard at that time from GAO about the importance of state auditors to detect fraud and improper payments in Medicaid. And one of the proposals that I kind of floated at the time, because it just came to me as we were listening to the witnesses, was perhaps we could get more states to do audits themselves instead of waiting on you all. By sharing some of the savings that they find, and whether it's intentional or unintentional, doesn't really matter, but overpayments that are made, by sharing a portion of that savings with the state. What are your thoughts on doing something like that to incentivize the states to do more state audits?
I think for strong program integrity, you want both people from a federal standpoint, both at CMS and OIG, GAO, being able to take a look, and you want people at the state level that know the individual state level dynamics and programs, including the state Medicaid agency and others, doing that sort of work as well.
And I appreciate that you want to do it. The problem is the states a lot of times don't have the money for their state auditors to go off and do this, which is why the idea came up that maybe if you shared some of the savings so that if you find, and I don't know what the right percentage would be, but if you find $100, the state would get to keep 20 of those dollars. I think that would then perhaps pay for the program and pay for the states to have auditors and have more auditors going in and checking on these things and make our whole system healthier. Do you not agree with that, at least philosophically?
We'd be happy to work through any details that's helpful. One thing I will note, coming from a state, is that when it comes to program integrity, including improper payments, states feel the budget pressure every day. When I was a Medicaid director and someone found a legitimate program integrity piece that I could act on and yield savings and administer the program in conformance with all laws and regulations, I would jump up and down with excitement. States have a strong interest in being able to find things of that sort, and so I think that's why there is both interest and real value in states being able to do a lot of program integrity work.
Well, I look forward to working with you on that because I do think it's important that we try to figure out a way to do that, and it's just human nature. If I'm going to get a piece of the action, I might work a little bit harder. Not that the chief guy won't be excited if we find something, but, you know, if I'm one of the auditors, I'm thinking, yeah, I can really help my state out if I find something that's not being done right. I
We'd
think
be
that
happy
just
to follow up with your office
incentivizes.
on that.
Yeah,
Thank
I
you.
appreciate it, and I yield back, Mr. Chairman.
Gentleman yields back. Chair recognizes Dr. Ruiz for 5 minutes for questions.
Thank you, Mr. Chairman. With an aging population in the United States, the importance of a strong long-term care workforce and reliable long-term care facilities like nursing homes cannot be understated. Our seniors rely on these vital services for the care they need to maintain a healthy quality of life. However, the nurse-to-resident ratio at many nursing homes is abominable and unsustainable. When nurses or nurse aides are responsible for caring for too many patients at once, staff all too often experience burnout, which leads to turnover. When burnout occurs, vulnerable residents can fall through the cracks. Errors can be made, treatment is delayed, because their nurse or nurse aide cannot be everywhere at once. The CMS minimum staffing standards finalized rule addresses the issue of dangerous understaffing in long-term care facilities. The rule does include temporary hardship exemptions that address concerns that some long-term care facilities face challenges in hiring and retaining staff. So there are some exemptions there. However, one of the bills before this subcommittee today, H.R. 7513, the Protecting America's Seniors Access to Care Act, would undo this important safety measure. It would also prevent CMS from finalizing similar rules in the future. Failure to act to mitigate chronic understaffing in long-term care facilities puts patient safety and lives at risk. So, Mr. Tsai, how widespread is the problem of understaffing in long-term care facilities that Medicare beneficiaries rely on?
Thanks for that very important question, and as a physician, you're well aware of the importance of appropriate clinical staffing, and so thanks for your attention on that. I mean, the number one concern I and my colleagues here when we talk to nursing home residents and family members is, can I be assured that my loved one is going to have safe and sufficient care? And usually that comes down to questions of, as you noted, staffing, not only the registered nurse piece for some clinical emergencies that might happen at various hours, but also having a nursing aide available to help turn an individual sufficiently to not have bed sores. Or there are really sad stories out there we hear directly of someone needing to toilet, not having access to nursing aid for 45 minutes and having to toilet in their bed. That's not what any of us would accept for ourselves, our family members, and really what the rule tries to do, as you note, is to establish some minimum reasonable.
I want to give it a little more doctor talk and a little more understanding of those two examples, because those were two examples that came to my mind immediately. One is the fact that they can't rotate a patient. If they don't rotate a patient periodically and timely, then they can develop bed sores. Bed sores can become infectious. They can get into their bloodstream. They become septic. They go into shock. And for an elderly person, that's very dangerous. There's a high mortality rate for that. So it can save lives. The second one is that they soil themselves. And they sit there in that soil, which can cause UTIs, which can then become kidney infections, which then becomes sepsis, and again, they can die. So we're talking about life and death here.
Absolutely. And I don't think we need to choose between a nursing home's economics, recognizing legitimate workforce challenges that we all need to work on creatively together, and safe, dignified care. And as you noted, the rule that was finalized upholds a standard but creates time and exceptions as well.
And so how would this minimum staffing standard rule impact patient safety outcomes in long-term care facilities?
Well, the evidence is very clear around what some of the staffing standards should be, and that you need staffing to have not only safe but quality of care. And so that is incredibly important in making sure that we're able to deliver quality care across everybody receiving services in the program.
You know, I think the best way to view this nurse-to-patient ratio is that it is patient-centric, not nurse-centric. It is patient-centric. It is for the patient, because when you have an overworked, burnt-out, fatigued nurse, patients are ultimately at risk. risk for not getting their medications on time, risks of not being appropriately attended to on time, and those risks can develop into severe illnesses that we just mentioned. So it is important that we help improve patient care, patient-centric care, by providing patients an adequate and safe ratio of nurses to patients. And with that, I yield back.
Gentleman yields back. The chair recognizes Dr. Bashan for 5 minutes for questions.
Thank you, Mr. Chair. I appreciate the opportunity today to discuss how we can best support our state Medicaid programs. Let me just say this, federal staffing mandates will backfire. Facilities will close. The staff just are not available. Facilities across my district have told me so. They all have job postings. They all want more people. The employees just are not there. You cannot expect salaries to increase when Medicaid is the main provider and Medicaid's reimbursement isn't increasing. It just doesn't work. So I'm going to pivot. There's an issue I'd like to address that isn't covered by today's legislation. Section 203 of Title II of the Consolidated Appropriations Act of 2020 changed the formula for calculating an individual hospital's Medicaid dish cap. While I recognize the intent was to address the issue of Medicaid patients who are dually eligible for commercial or Medicare coverage, this policy has resulted in unintended consequences that have negatively impacted hospitals in my district and across the country, many of whom treat our most vulnerable constituents. Section 203 did include a 97th percentile exception for those hospitals that meet certain criteria. Unfortunately, this policy has created an arbitrary threshold which leaves behind many hospitals and creates year-over-year uncertainty should there be changes to a hospital's payer mix. I certainly appreciate the difficult task CMS faced in identifying those hospitals that qualified for the 97th percentile exception. Upon completion of that process just a couple of weeks ago, CMS identified only one hospital in the entire state of Indiana that qualified. Indiana University, the largest health system in the state. Surprise. It wasn't Good Samaritan Hospital in my district, a small, relatively rural hospital that now faces a yearly loss of $3.8 million, nor was it Eskenazi Hospital, a large safety net hospital a la LA County or Cook County in Indianapolis, which faces a loss of $36 million. And it wasn't Methodist Hospital in Gary, Indiana, which faces a yearly loss of $27 million and is currently at risk of closure. I could go on. One more, South Bend Memorial faces a yearly loss of $13.5 million. Given that Indiana hospitals face a loss of $120 million statewide because of Section 203 implementation, I'm very concerned that Methodist Hospital in Gary won't be the last one that closes in my state. It's not just Indiana. My colleagues on the other side of the aisle from New York have hospitals that are at similar risk, where 9 hospitals, ranging from academic medical centers in urban areas to critical access hospitals on the Canadian border, are facing a combined annual loss of $290 million. So the question I have is, I want to confirm that there isn't anything CMS could have done to interpret Section 203 differently and allow the agency to better tailor exceptions to hospitals that truly need it. Is that the case?
Thanks for that. And I appreciate your focus on safety net providers and making sure there's sufficient reimbursement. I think that's absolutely critical, and it is a shame that we have so many providers across the country providing care to our members at real fiscal challenges. You are correct. Our team implemented the statute, which was exceedingly clear on how to calculate that 97th percentile, which was done at a national level, and so there was no policy discretion for CMS in this area. Our staff implemented the statute.
Okay, great. I mean, Eskenazi Hospital, like I said, it's like Cook County or Grady Hospital in Atlanta or LA County. Level 1 Trauma Center serves underprivileged citizens, $36 million loss based on this. It's going to be a pretty hard.
That is a challenge.
Pretty hard to fix that, right? This isn't just big private hospitals in suburban areas, you know, with a bunch of wealthy people going there. This is Gary, Indiana. You probably may or may not know, Gary, Indiana has been economically challenged over the years because of shifts in manufacturing and other things. Their hospital there, $27 million loss. it might close. What happens to access to the type of people we're trying to create access to. So in 2022, I co-authored a letter to congressional leadership on both sides of the aisle that called for a solution to the issue, and I now renew that call and ask for you to work with me and all interested parties to find a legislative solution that addresses this matter before the end of the year. So whatever input you or your office may have on ideas about how we can address this, I'd appreciate that.
We'd be happy to work with your office. Thank you.
Thank you. I yield back, Mr. Chairman.
Chairman yields back. The chair recognizes Ms. Dingell for 5 minutes for questions.
Thank you, Mr. Chairman and Ranking Member Eshoo for holding this hearing. I'm so thankful that the subcommittee is taking on one of the issues that I've been fighting for throughout my time in Congress supporting the long-term care system. Systematic changes, as we are considering today, are vital. But we also have to consider a more robust financial investment in the HCBS. I've talked about it before. I'm not going to, because time is tight, not going to do it today. But our long-term care system is broken. And I'm grateful that 2 bipartisan bills I'm leading are included as part of today's hearing. The first is H.R. 8109, Money Follows the Person Permanency Act of 2024, and H.R. 8110, Protecting Married Seniors from the Impoverishment Act of 2024. I'd like to begin with the Money Follows the Person program. This program has demonstrated it works, has strong bipartisan support, and saves taxpayers money by successfully transitioning thousands of people from institutions to a community setting where they can be with those they love. Currently, the program will expire in 2027, and my bill, instead of this constant having to renew it, would authorize it permanently and take away a lot of doubt and insecurity. Money Follows the Person allows certain Medicaid users, such as seniors and individuals with disabilities, transition from a nursing home or institutional care back to their home. Since the MFP program was created over a decade ago, it has successfully helped over 88,000 individuals receive care in their own homes. Mr. Say, how would authorizing this program permanently improve the quality and the efficacy for Medicaid users?
I appreciate that. I appreciate your attention to the Money Follows the Person program. And while I can't comment on any specific legislative proposal, I can affirm that that program it works. It has an incredible impact on helping people move from a nursing home or an institutional setting and to be set up so they can reside independently in their home. It's cost effective. It's common sense.
Could you address the administrative ease a permanent reauthorization would have on the program?
From an administrative standpoint, whenever there is uncertainty about timing of a program, it leads, coming from a state, it impacts decision-making because you don't know how long you have access to funding. And so certainly with respect to uncertainty and certainty, those are really important for how states and local stakeholders make decisions.
Okay, now I'd like to address protecting married seniors from the Impoverishment Act of 2024. This is another program that needs a permanent reauthorization. Spousal impoverishment funding is intended to prevent individuals married to someone who requires long-term care and services under Medicaid from spending down all of their assets to qualify for Medicaid. This program allows the spouse to retain a modest amount of their assets to cover basic living and health expenses. In addition to this community spouse resource allowance, the program entitles the community spouse to a minimum monthly maintenance need allowance. It's not a lot of money. Finally, it ensures that Medicaid does not count the spouse's income when determining whether the institutionalized spouse is eligible for Medicaid. Again, this program is set to expire in 2027, and my bill would authorize it permanently. Mr. Sy, in some states, if the community spouse's income exceeds a certain threshold, they may be liable for court-ordered support for the cost of the sick spouse's care. How would permanently authorizing the exclusion of a spouse's income improve access for the beneficiaries?
I appreciate that question. We want to make sure that as many people as want it and need it can access home care, and part of what you're raising is right now, in terms of how some of those things are dealt with, there is a bias towards institutional settings, meaning it's more difficult around those things to receive home care. And we certainly have supported and worked with states in trying to find a better balance so that there is not a proclivity to have someone in a nursing home because of a whole range of things, including how spousal assets are dealt with.
In the 30 seconds, how would permanent reauthorization allow the spousal impoverishment program to work?
Again, as a general comment, I think anytime there's something, when there's uncertainty, it makes, there's more hesitation for states and others to take things up because of not knowing how long authorization will continue for.
Thank you, and I yield back, Mr. Chairman.
Thank you. The gentlelady yields back. The chair recognizes Dr. Dunn for 5 minutes for questions.
Thank you very much, Mr. Chairman. Thank you, Mr. Sy, for appearing before our committee today. I'd like to begin with a question regarding the 80-20 rule, which requires the HCBS providers to spend at least 80% of their Medicaid reimbursements on compensation. Unfortunately, that seems like a top-down, one-size-fits-all mandate. I think it's misguided and will actually lead further instability in the home community-based workplace instead of its opposite effect, which is intended to improve that. My colleague from Florida, Ms. Kamek, has introduced H.R. 8114 to block the rule, and I agree we need to rethink that approach. I've heard from individual providers in my district as well as national associations such as the National Association of Home Care who project that the regulation is unsustainable, will lead to limited services and increased costs. I also have concern about the rollout of this new requirement giving CMS's track record working with states like Florida on needed flexibilities and tailored approaches that best serve our managed Medicaid programs. And in a concerning pattern, frankly, of CMS setting policy via frequently asked question documents. So, Mr. Sy, in your statement, you claim the Medicaid access rules are necessary to cap administrative overhead or profit. What do you believe are those inappropriate activities, profits, I should say, that currently exist in Medicaid in this program, makes this rule necessary? What is that?
Well, I appreciate that question, that focus, and as I mentioned before, we want to make sure people have access to care, and it's high quality, and having, everyone here has noted the workforce challenges, having a sufficient workforce, the ability to attract and recruit that, is paramount to be able to have access. On the 80-20 piece, the rule requires that Medicaid rates for home and community-based services are meant for direct care, and it ensures that 80% of the rate goes to actual direct care workers. The administrative overhead and profit, most providers I know are deeply mission-driven and committed, and so this is not questioning that, but it is making sure that there is good fiscal stewardship as well of scarce Medicaid resources.
I would tell you that some of the resources they provide in the home are quite expensive. Ventilators come to mind and whatnot. So I think that there's expenses there that wouldn't fit in the compensation bucket. But that's how does CMS actually define the operating margin for an HCBS agency?
So again, the details of the rules are meant to ensure that a sufficient portion of the payment go to direct care workers, and the way we specify that is to really take a look at how much of the rate that a state Medicaid agency pays to the home care workers, not for ventilators, not for the other durable medical equipment, how much of that rate goes to direct care. And in the final rule, we made multiple changes based on a lot of the comments that we received, one of which being providers should get credit for things like travel costs for a nurse across the state, PPE, training, and other things of that sort.
Can you give me sort of a simple average operating margin for Medicaid HCBS agency? Do you have a number?
Sure. It certainly varies across entities.
Average.
All across. The part of fiscal stewardship is making sure that payments from a state Medicaid.
Do you have a figure for that? I had a figure for my practice when I was practicing.
I'm well aware of individual EBITDA margins across for-profit and not-for-profit home care providers. We've taken a look at those, and part of what the rule also does is to have transparent reporting across the
Right,
country.
so I don't think we're going to come up with a number here. Let me ask you a different question. I'm also concerned with the delay in improving the expansion of Florida's CHIP program, which we call Kid Care. This is a children's health insurance program. And we're having terrible delays on this. This is really a terrific program. To be clear, Florida wants to put more kids in the program, not less. So this is a plus for the beneficiaries. But CMS's orders, again, some frequently asked questions style guidance preventing disenrollment of individuals related to failure of premiums. These are premiums like $20 a month. And these are people who make up to 300% of poverty level, federal poverty level. So I mean, I think that's reasonable. Can you address that?
Sure. I mean, our goal is to make sure that eligible kids, I'm sure we all want eligible kids to be covered by Medicaid and the Children's Health Insurance Program versus being uninsured. And we also appreciate that Congress provided a statutory requirement for 12 months of continuous eligibility for all kids across the country. And we are making sure that we're implementing our understanding of the statute.
Well, I'd like you to work with Florida, if I may. Mr. Chairman, my time's expired. I yield back.
Gentleman's time has expired. I'd like to, everybody's hearing the bells and whistles. There is a vote on the floor. We're going to try to continue for at least a couple of more, but then we will have to reconvene after votes. And so thank you for your willingness to do that. And the chair will now recognize Ms. Kelly. She's up for 5 minutes for questions.
Thank you, Chair Guthrie and Ranking Member Eshoo, for holding today's hearing. In Illinois, the Medicaid Prospective Payment System, PPS, for community health centers is designed to provide reimbursement that accounts for the costs of service, expansion, and delivering services to all individuals who seek care. However, there are concerns that the PPS rates in Illinois only cover just about 60% of the actual costs incurred by healthcare centers. And if you compare Illinois' PPS rates for behavioral health services, our members receive maybe 1/3 of what their counterparts in our surrounding states receive. This indicates a significant gap between the reimbursement rates and the operational costs of providing comprehensive care. What steps can be taken to ensure these rates are adjusted to reflect the operational cost of health centers more accurately?
Sure. Thank you for that. Health centers. I think health centers are an incredibly important part of the Medicaid program. This is not just for your state, but across the board. They are a good investment. They provide primary care. They often do behavioral health and dental. They're scrappy. They're cost effective. I think they're really good. There's also statute, as you know, BIPA, that has clear federal statute around how states need to set the PPS rate for federally qualified health centers, and we work with all states to make sure that they are able to comply with that. And in addition, I would say we continue to encourage and support, and we have a range of policies that we put on the table, continued investment in health centers and primary care, because I think it's a very, yields a high return on investment for the program.
Thank you. How do you envision the future of the Medicaid Community Health Center PPS, and what changes are being considered to improve its effectiveness and sustainability?
So I think it's critical that health centers can be sustainably reimbursed and also consistent with federal statute. They play a critical role, and with every state, we are, I think, routinely in dialogue around how they can best both utilize the PPS rate, but also there are a number of states that have utilized a part of the statute called the APM, an alternative payment methodology, where they pay above the PPS rate, value-based, with quality, to ensure there's both sufficient funding for primary care and health centers, and also that there are other programmatic benefits. We think those are really exciting approaches as well.
And are there states that you think, I guess comparable states that you think that you would hold up as a model, or is that hard to do?
There are a range of states that I think do a really good job, including using the APM methodologies. We'd be happy to follow up with your office on any specific state examples, if that would be helpful.
Okay, you don't want to call one state. Okay, thank you, Chair. I'll yield back.
Thank you. Gentlelady yields back. Chair recognizes Dr. Joyce for 5 minutes for questions.
Thank you, Chairman Guthrie and Ranking Member Eshoo, for holding this important hearing today. And thank you, Mr. Sy, for testifying. The Medicaid program is an essential resource for America's most vulnerable populations, including children and those with disabilities. It is encouraging to see that this committee continues legislation, much of it in a bipartisan fashion, which will only help to strengthen this critical program. Many of the proposals today will make common sense changes to cut down on improper payments and combat fraud. Other proposals will push back on federal mandates to threaten access to home care and long-term support services for beneficiaries by imposing unattainable requirements. As we examine these potential changes to how the Medicaid program is administered, we must consider how they will help achieve the goal of continued access to high-quality care for beneficiaries through efficient use of Medicaid funds. Mr. Tsai, when CMS evaluates potential roles for Medicaid coverage, how do you balance expanding access to more beneficiaries versus considering access to enhanced services for each beneficiary that is already covered?
I appreciate that. Both are important, and as you know, we want to make sure from an access standpoint and coverage standpoint, eligible people can enroll and easily enroll without red tape, and that the services that people enrolled receive are sufficient and really help improve their health, and that is a constant ongoing dialogue that we have with every state Medicaid agency, which, as you know, makes a lot of their individual choices for what to cover and how to do so in that particular state.
I worry that with new federal rules expected to cost billions of dollars to the Medicaid program over the next decade, states will be forced to balance their cost in one of two ways, either by cutting reimbursement or cutting optional services like home care and community-based services. Both of these actions would have devastating effects on access to care. And if this happens, Medicaid will fail to match its intended purpose for its intended population. Do you feel through which process does CMS ensure that new rules and increased spending will not lead to cuts to services for beneficiaries?
So we're highly interested in making sure we can both achieve clear federal policy goals and what our statutory objective is, which is to make sure there's coverage and access for people in the program, including quality coverage, and that we are working with our individual state Medicaid agency partners on the budget and operational
Do you see this able to occur without cuts to home care or community-based services?
Every state Medicaid agency I talk to fundamentally believes that it's important to make sure there is sufficient access to home care and nursing home facilities.
So you talk about your collaboration with state officials. How do you officially do that through CMS? And what type of contact are you having as moving forward with the state officials who are ultimately responsible for the administration of these Medicaid funds?
So again, we want to make sure across the program there's coverage, there's access, we're able to strengthen these programs, and daily we are working with state Medicaid agencies who are running and operationalizing their own programs at the state level.
I think that daily collaboration, I think that's important. Additionally, though, I'm concerned, especially in rural areas, like I represent in southwestern and south central Pennsylvania, that they're also facing shortages of healthcare professionals and paraprofessionals. Nursing homes, unfortunately, might not be able to meet the new staffing mandates. Mr. Tsai, how does CMS collaborate with state Medicaid programs when creating such staffing mandates? Is there a reality of health professional and paraprofessional shortages that's taken into account as you issue these mandates?
Well, as you're referencing, states are unique. They have different demographic compositions and so on, and we wanted to make sure that we could both affirm the ability for people across the country to have access to safe nursing home care through minimum safe staffing standards, but also to account for exactly some of the across the country variation that you mentioned. So the final rule does incorporate, for example, a longer time frame for nursing homes to come into 5 years.
But to your point, there are different demographics from state to state, and particularly some states have significant rural areas like mine in Pennsylvania. Does your collaboration allow for that to occur and to be recognized when you put out these mandates?
I can assure you our state Medicaid directors and counterparts are constantly raising things of this sort, and that is very much part of the daily dialogue that we have with our state partners.
Mr. Chairman, my time has expired. Thank you, and I yield.
Thank you. The gentleman, time's expired. We're watching the vote. We'll at least get Ms. Custer in. We hopefully can do two more, but Ms. Custer, you're recognized for 5 minutes. You're
Thank you,
recognized for 5 minutes for questions.
Thank you, Chairman Guthrie, and to Ranking Member Eshoo for holding this important hearing. And I want to thank the witness. You're about to get a little bit of a break when we go to votes. As we've heard today, Medicaid covers the most vulnerable populations in need of health care services. But unfortunately, this does not include individuals who are involved in our criminal justice system. The Medicaid inmate exclusion that most of my own colleagues don't know about because it happened over 50 years ago before any of us were here when Medicaid was created, bars coverage of all healthcare services for incarcerated individuals, including mental health and substance use disorder services. This has been extremely expensive for our society. If you multiply out 50 states for 50 years and take away the very services that people might need in terms of mental health, trauma, treatment, dealing with addiction, and substance use disorder, that's why we have these incredibly high recidivism rates. Without Medicaid coverage, states and localities struggle with the costs of providing these services, and frankly, the services are inadequate. Studies show that for every dollar we spend to treat substance abuse in our prisons and jails, we can save up to $7 down the road. So it's a $1 to $7 savings. That's an incredible return on investment. We should be doing more to maximize effective cost-saving treatment, and that's why I introduced the Rehabilitation and Recovery During Incarceration Act. This bill, which has bipartisan support, would reform the Medicaid inmate exclusion policies so that incarcerated individuals who are otherwise eligible for Medicaid would be able to access mental health and substance use treatment and recovery services during incarceration. Failing to provide medical coverage to incarcerated people leads to worse health outcomes and increases the risk of serious illness and injury, and in fact, continued drug use in our communities. Mr. Tsai, how does providing health care to incarcerated individuals help our communities stay safe and healthy?
First, thank you for raising that, and I have to thank Congress for your leadership on this, and Congress for emphasizing some of the Section 1115 demonstrations we've done with states to make sure there's pre-release services for folks involved with the carceral system. I think this is really, really important. As you note, there's a strong ROI, and I think that's not just from a cost standpoint, but also from an outcome standpoint. We've also seen broad bipartisan support. The states that have come forward wanting to do this, I think, range the continuum because there is a lot of shared recognition and understanding that there's some very common sense principles here when someone is being released back into the community, having them set up with the right medication-assisted treatment, case management, having a mental health provider able to, that they can see on a consistent basis. Things of that sort are really critical, and we are excited to continuing to partner with states and this body on how best to continue supporting those efforts.
Perfect segue, thank you. In New Hampshire, over 50% of incarcerated individuals have an opioid use disorder. On one of my recent trips to our women's prison, 100% of the inmates in our women's prison have either sexual abuse or neglect in their childhood or some type of trauma that they've experienced. Failure to comply with treatment and substance use were among the top 3 reasons for parole revocations in 2017 and higher rates of recidivism. That's why it's so important, as you pointed out, that our New Hampshire Section 1115 waiver request gets approved. The state submitted its application in 2022, but it is still pending without a decision. Waivers like ours will support successful community reentry, as you've outlined, will improve community safety, and will save federal dollars in the long run. Mr. Tsai, what steps is the Centers for Medicaid and Medicare Services taking to expedite the review of these pending waiver requests?
Thanks for that. The flip side of having so much interest in this is that there are a lot of these 1115 demonstrations to process, and as you know, there's a whole outline path for that. We have, excuse me, fly there. We have put out both some consistent guidance about how states can implement these programs in a more consistent way that actually helps to speed up the approval. So we just met, I think, our team last week with a whole range of states with active 1115 demonstration proposals before us to talk about, I think for the first time, a more streamlined way to deal with multiple states who all have very similar requests at the same time. We hope that will help us be able to process and administer those as quickly
Kind of
as
running
possible.
low on.
Yeah, sorry, my time
Yield
is
back.
up.
We're going to try to get just
Thank you,
as
Mr. Chairman.
quickly
I
as,
yield
you-
back.
as Dr. Meeks. You're recognized for 5 minutes until we have to adjourn.
Thank you, Mr. Chairman, and thank you, Mr. Sy, for testifying before the subcommittee today. Mr. Sy, you're probably aware that the recent federal regulations are expected to add over $100 billion in new federal spending to Medicaid over the next 10 years. Because this will also have fiscal implications for states, especially states like Iowa with large Medicaid populations, it's important that Congress and the CMS work together to ensure the original purpose of Medicaid remains available to those who need it. My bill, H.R. 8111, the Medicaid Program Improvement Act, co-led by Congressman Cartwright, would create a process for state Medicaid programs and managed care organizations to obtain address information of program beneficiaries to ensure they are not enrolled in multiple states' Medicaid programs. This good governance legislation would maintain program integrity and help control unnecessary costs to states and the federal government without restricting access to those who legitimately qualify for Medicaid. Congress and the administration have learned a lot about outreach to beneficiaries from the redetermination process. What important lessons should Congress consider to support state outreach to beneficiaries? And do you think ensuring people are not enrolled in multiple state programs is good for program integrity? Similarly, how is Congress supposed to interpret your agency's statement via FAQ in October 22, where you directly tell states not to pursue or prosecute even those convicted of fraud?
Thanks for all this. So I think first, we want to make sure eligible people, as you noted, can be enrolled in the program, and that's who we're serving through the program. And I can't underscore enough how much we agree wholeheartedly. Program integrity, good government that both reduces red tape, doesn't put undue burden, and also ensures that eligible people are receiving and being paid for services. That is, I think we very much agree on. And so Medicaid, the deceased enrollee question came up before. You raised a good piece around enrollees in different states. We wholeheartedly agree. Those are very important program integrity initiatives, and we support and are working with states on those.
So states could pursue or prosecute those convicted of fraud.
On the fraud question, I just want to be clear. The guidance we put out, two important things. One is that when there is suspicion of fraud and things of that sort, any of us, federal and state level for the Medicaid program, we are not law enforcement agencies. States and we are required to refer those cases to law enforcement. The guidance is around making sure that from a state Medicaid administrative process, there is due process for individuals, but nothing around that changes any of the obligations and the work of law enforcement authorities.
And when you were the
I think,
Medicaid...
we probably let you continue. If you want to come back and do your final 2 minutes, or if you want to yield back, that's fine. But I think we're getting close on vote time. We're going to have to
Okay, then I will yield back.
yield back. The gentlelady yields back. The subcommittee will now recess for votes on the House floor. We will reconvene 10 minutes after the last vote is called, and the subcommittee is in recess.
tell me when you're ready. You ready? Subcommittee will come to order. I now recognize Ms. Schreier, 5 minutes.
Thank you, Mr. Chairman, and thank you, Director Tsai, for being here today with us. As a pediatrician, I know how important Medicaid is for children, particularly children with disabilities. Almost half of the children in the United States are insured through Medicaid, and so the best way to take care of our kids is to strengthen the program. That's why I introduced the Kids Access to Primary Care Act, which would require any Medicaid primary care services to be reimbursed at least at the same rate as Medicare. Doing so would be fairer reimbursement and would increase the number of available physicians, reduce waiting periods, and increase healthcare coverage for families on Medicaid. Mr. Chairman and Director Tsai, I look forward to working with you on this bill. As everyone has said before me, Medicaid is a critical program for our most vulnerable, so making sure that Medicaid reimbursement rates are fair, or at least fairer, is important to maintaining access to care for patients. Now shifting gears to the bills before us today, as a physician, I'm particularly interested in oversight over the Medicaid managed care organizations, the MCOs. In Washington State, I generally hear positive things about our MCOs because the Washington State Healthcare Authority, which oversees them, is responsive and proactive when it comes to concerns. However, I want to make sure that all states have the necessary oversight tools to respond to concerns with MCOs that may arise from providers or patients. Currently, states have sort of an all-or-nothing approach for MCOs that violate conditions of the Medicaid program. And this one-size-fits-all approach is in place despite a pretty wide range of violation severity. So, Director Tsai, in your professional experience, would having additional, perhaps more proportional options to address violations committed by a managed care organization be helpful or appropriate?
Thanks for your comment around adequate reimbursement to Medicaid providers. That is critical. It's consistent with a lot of what we have tried to put forward in rules as well. So thanks for your continued attention to that. And on Medicaid managed care is 70 to 80% of our enrollees now get their care through managed care. There are incredible things health plans can do, and we want to make sure, as you noted, we have strong oversight and accountability for plans. The president's budget included at one point a similar piece, which is, as you noted, having more tools in our toolkit to be able to hold health plans, managed care plans accountable for compliance issues that we don't otherwise have today.
And of course, compliance issues could be anything from documentation to really malpractice. And so we might want to think about having a more proportional response. I want to shift gears a little bit again to touch on the pediatric home and community-based services. Access for pediatric home and community-based services is a lifeline for families with children that have significant care needs. However, this important Medicaid program has been hindered by pediatric caregiver pay that's actually below the pay for adult services, and yet which requires a greater degree of training. Ensuring adequate training and levels of caregiver pay would be critical to safeguarding this really important healthcare access for our youngest patients. And so, again, Director, how will Medicaid's recent rulemaking help to ensure adequate caregiver pay and training to level that playing field for access specifically to pediatric home and community-based services?
Well, thank you for that. As someone on my team likes to say, kids are not just little adults, and so there are really unique care needs that kids have, and we want to make sure both for home and community-based services, also pediatric care, mental health services, there's sufficient access. And so there's a few things. One is, in our recent rules, to really support access, we are requiring that states report to us the rates that they pay across the board and for a range of services that would help identify some of these things. That would be a very important piece. And second, one of the areas I hear most about from parents with medically complex kids is how difficult it is to get access to, say, 24/7 nursing required for a medically complex, maybe vent-dependent kid to be able to be supported at home. And so we both are requiring states to actually measure for the first time how long it takes to wait to get services, and also, specific for kids, the percent of hours that a kid needs. Say if you need 10 or 12 hours of nursing, how many is the parent actually able to fill? That gives a really important measure of whether there is sufficient access.
Thank you. I'm out of time. I look forward to working on coverage of dental care too for kids, and I yield back.
Thank you.
Gentlelady yields back. Now recognize Mr. Bilirakis for 5 minutes.
Thank you, Mr. Chairman. I appreciate it very much. Again, thanks for holding the hearing, the legislative hearing, to examine Medicaid and ensure program integrity and targeted help for individuals who are often the most in need. Children, low-income seniors, and those with disability. Republicans are also pushing back on significant overreach from this administration in its attempts to federalize the Medicaid program into a one-size-fits-all approach that will harm patients' access to care, in my opinion. We should reject policies that further this overreach and instead empower states and providers. That's why I'm in support of Representative Kamek's H.R. 8114 legislation that prevents CMS from finalizing its 80-20 rule. That would be catastrophic for Americans that rely on long-term services, especially now, and supports an increase the shortage of workers we already have. So we've got to be careful. The staffing issue is a real problem, particularly in the state of Florida. Among our other proposals are common sense bipartisan solutions such as Representative Miller Meeks' H.R. 8111 that ensures streamlined updates of Medicaid beneficiaries' address information, and Chair Rogers' H.R. 8106, which allows states to provide home and community-based service options for those that don't meet an institutional level of care. Vital. Quality of care, quality of life is so very important for our seniors. As well as my bill, H.R. 8084, the Leveraging Integrity and Verification of Eligibility for Beneficiaries Act. This bipartisan bill I lead with Representative Craig will address concerns that many states repeatedly have made improper capitation payments to managed care organizations after enrollees had died. So this is a real issue, folks. This is a no-brainer policy, in my opinion, and yet it's a serious issue, very serious issue, since we know there's also a lot of fraud that can and does occur. Mr. Tsai, I wanted to thank you for your recent state Medicaid director letter sent last week that addresses these concerns with deceased beneficiaries remaining enrolled in the Medicaid program. As you know, this was also a subject of the oversight hearing in this committee a few weeks ago as well. In the letter, you noted that the identification that a beneficiary is deceased should be considered as a, and I'll quote, potential change in circumstance, and that states must conduct a redetermination of eligibility. About how long would that redetermination process take for a state to confirm that someone is in fact deceased?
Well, thanks for that question, and thanks for your focus on that topic and program integrity. I want to just start by saying we agree very much. Not only is program integrity and fiscal stewardship important, Medicaid should not be paying capitation. Premium payments to Medicaid managed care plans should not be paid with Medicaid dollars. We have clear rules that say we recoup funding, and so you referenced the letter we put out last week. I would note, with respect to the provisions you're noting, one important thing that I would know we all agree with is as states and managed care plans are doing data matches to help identify if someone is deceased, number one, we just want to make sure those are Correct. Obviously, sometimes a data match happens and you think someone is deceased, and the worst thing would be to send a letter to say your husband is deceased and disenrolled from the Medicaid program when it was due to a data error. And so we work with states to make sure they can do that, but do that as quickly and efficiently as possible.
Okay. So the death master list is considered to be highly accurate by the Office of Inspector General. And they believe that the likelihood of false positives where someone who is alive is reported in the database is near zero. So do you think it's prudent that states should be required to pay for at least one, if not multiple, per member per month payments to Medicaid managed care organizations when they know that someone is already dead? So if you could answer that question, I'd appreciate that.
Sure, and as I noted, we agree that not only is fiscal integrity important, as I said, Medicaid capitation payment should not be paid out for that, and states have a strong incentive to do this as quickly as possible because they know if we audit, if we identify, or OIG or GAO audit, we go recoup that funding from the states, and so they are on the hook. And so there's a strong incentive from states to utilize a range of files. Sometimes the data match is not just the issue with the death master file itself. It is with matching between the data set that the state has to that and making sure that that is accurate. And again, no one wants to get a letter in the mail that says somebody has deceased when they've not actually. And so there are pieces there, but we ask states to do that as quickly and efficiently as possible.
Very good. Thank you. I yield back, Mr. Chairman.
Gentleman yields back. Recognize Ms. Pentagon for 5 minutes.
Thank you, Mr. Chairman. Thank you, Director Sy, for your work and for being here today. I want to echo that Medicaid serves as a vital safety net that provides essential health care coverage to millions of low-income Americans, including about 12 million Californians, where my district is. We have seen over 20 million people been disenrolled from Medicaid after the continuous coverage requirements expired a year ago, and many of those were disenrolled for procedural reasons. And it's important, I think, that states have flexibility and resources to help eligible people renew their Medicaid coverage during the process. One bill in today's hearing, H.R. 8111, would put into statute and expand one flexibility provided by regulation, which requires the managed care organizations to report updated address information to states. Can you share a little bit about why it's important to keep flexibility such as this one to limit how many people lose Medicaid?
Thanks for that question and focusing on, we very much agree with. We want to make sure eligible people, kids, adults, others in the program can successfully renew their coverage with as little red tape as possible. That's good government. And we have focused on doing that with states, including, as you're referencing, during this whole Medicaid unwinding process where states have had to do redeterminations. We have provided important and significant policy flexibilities. Many are very common sense to help be able to renew someone without undue burden and a lot of red tape. And as you're noting, included in those policy pieces are various options to get more updated contact information, including using health plans to help support that. Because clearly, if you're sending a letter out to renew someone, you want to make sure that letter is getting to the right address, the right person at the right address.
Well, thank you. I want to also talk a little bit about the HCBA program, the Home and Community-Based Services. First, I was ecstatic and very pleased to see the President's budget proposal include $150 billion over 10 years for Medicaid home and community-based services. This is the program that allows Americans and people with disabilities to remain in their homes and supports family caregivers. I'm a primary caregiver myself. Didn't even learn about the program until half my time into Congress. I think I was in about 3 years. And it's so critically important that we give people that option and availability to stay in their homes. And so I was really happy about that. Can you talk a little bit about how this investment for the home and community-based services program will help support family caregivers?
Of course, and thanks for your caregiving, and thanks for also noting this is, it is very important that people have access to home care, home and community-based services so that people can either age in place or remain in their home independently or as independently as possible if they so desire. And having strong access, having caregivers is really important, and that is true very much on a lot of the rules and policies we have put forward to make sure the direct care workforce is able to be retained and sufficiently compensated. On family caregivers, excuse me, I think that's a very important piece as well. We have worked with a range of states who have come to us and we have approved various ways to help support and give family caregivers respite in appropriate situations. We've also helped for medically complex kids. There are a lot of parents that have been able to help provide critical support during a workforce crisis, and we have worked with states with the right supports to be able to affirm and support that as well.
Well, thank you. I mean, there's a huge other benefit. If, for example, my mother has Alzheimer's, she needs to stay in that familiar home and setting, which I believe could extend her life and extend her experience and her memories. So thank you for that. Now, my mom was on the waiting list for several months to get into the HCBA waiver program, and that's one reason I think the proposal, the president's budget proposal is good. In California alone, there are 4,720 people on the waiting list just to be able to access this critical program. Now, the final Medicaid access rule requires states to report how they establish and maintain home and community-based services wait lists for waiver programs and assess wait times. Could you share how these requirements can help improve access to the program?
Absolutely. We want to make sure that access is available for any Medicaid enrollee that needs it, precisely for the reasons you mentioned and some of the benefits for your mother, for someone being able to stay in their home. And unfortunately, across the country, there are wait lists for access to home and community-based services. However, we at CMS have not had consistent data to oversee, to monitor, to work with states around that. So the new regulations actually require states to report what those wait lists look like, and we'll work with them to make sure those are as apples to apples as possible, and that really starts to tackle that important issue you raised.
Great, thank you. I yield back.
Gentlelady yields back. Recognize Mr. Carter, 5 minutes.
Thank you, Mr. Singh, for being here. Appreciate it very much. You know, I'm from the state of Georgia, and our population is booming, particularly our elderly population. As a lot of retirees are coming to our state, and certainly that's important. Professionally, I'm a pharmacist. In fact, more specifically, I was a consultant pharmacist at nursing homes. I reviewed patients' charts, made recommendations for senior citizens, and I've probably... I suspect, I don't know, but I suspect I've spent as much time in nursing homes as just about any other member of Congress, if not every other member of Congress. And I've seen it firsthand, and I've seen the struggles of nursing homes firsthand. And that's why I'm so concerned about the nursing home minimum staffing standard rule. And you know, when it comes down to it, and I've often said this, we all, whether it be a Republican, a Democrat, or an independent, we all want the same thing. We want accessible, affordable, quality health care. Everyone wants that. And I'm worried about the accessibility of this. I'm worried about what impact that this rule is going to have on accessibility for senior citizens to the nursing home setting. It's been estimated in Georgia that it's going to result in 10,000 senior citizens not being able to be in a nursing home. And I'm very concerned, as I say. Let me ask you a yes or no question. Do you believe that a rule that decreases accessibility and increases healthcare costs is in the patient's best interest?
Thanks for that question.
It's simple, yes or no. Do you believe a rule that decreases accessibility and increases healthcare costs is in the patient's best interest?
I believe that we, as federal regulators, need to make sure there is safe access for everyone residing in a nursing home.
Okay, I can see you're not going to answer that. So let me ask you, what is CMS's response to an independent analysis that several nursing homes in Georgia will be forced to either reduce capacity or close due to the nurse staffing rule?
I think, again, everyone that lives in a nursing home, or if you are a family member with a loved one in a nursing home, has the right to know that that nursing home is able to provide safe care, and the rule really reaffirms that. I also acknowledge, I know a lot of individual nursing home operators. They're good people that want to serve their residents, and there are workforce challenges. And we heard many comments, had many discussions with the industry and others, and that's why the rule really gives a balanced, staggered approach to
But if it's going to result, as this independent study has said, if it's going to result that several nursing homes in Georgia close and that they'll be forced, that some will be forced to reduce capacity, where are the seniors going to go? Where are they going to go if they can't go to the nursing home?
So the final rule makes some important adjustments to account for comments we made, really to help preserve access to safe care, including extending the timelines, having exceptions. And I don't believe we should choose or have a binary choice between a nursing home's economics and safe care in those nursing homes.
Aren't nursing homes, unless it's changed since I've been in nursing home, and listen, I have spent countless hours in nursing homes. And I mean, countless hours in nursing homes, probably 40 or 50 hours a week at one point in my career. And I know about the challenges in nursing homes. I know them firsthand. I've seen them. I've experienced them. But let me ask you, what kind of data, do you know what continuum of care is, where, you have a senior citizen who goes into a hospital and then they are going into a nursing home for rehabilitation and then they hopefully get to go back home? Well, what kind of data did CMS look into to suggest that the nurse staffing rule wouldn't impact the continuum of care for seniors?
Well, I'd say two things. First, the evidence is clear, and as a clinician, you know that staffing is critical for safety and quality, and there are clear clinical standards around what safe care looks like, but there's also a time frame for implementation.
I'm not arguing that. That's a given. But at the same time, nursing homes go through inspections. Nursing homes go through inspections quite often, and they have to meet certain guidelines, and they have to meet certain standards in order to get relicensed. What's wrong with the rule as it is now and what they've been doing?
I think there are real challenges in the status quo around quality of care, and the rules really focus on access to safe, quality care for everyone that needs to, wants to.
I understand. Let me ask you, and with all due respect, and I do mean it respectfully, when's the last time you were in a nursing home? Listen, I've been in nursing homes late at night. I've been there on weekends. I've seen it firsthand. When's the last time you were in a nursing home?
I've spent significant time in nursing homes with staffing, with nurses, with patients, with families. The number one...
Significant time? Being?
Yes, especially during COVID. On the ground, in facilities.
Well, you must have gotten a free pass, because during COVID, the nursing homes, the family members weren't able to go in. They had to go to the windows to see the patients.
The number one thing I heard from family members and residents of nursing homes was, how do I make sure my nursing home is able to staff safely? And that is really what the rule focuses on.
Well, I can't help but disagree that this is going to result in nursing homes reducing capacity and closing, and I don't think that's good. We agree that they should have proper staffing, but I would submit to you that that's why we have licensing, and that's why they have reviews, and that's what they have to pass. Thank you again for being here.
Thank you.
And I yield back.
Gentleman yields back. Recognize Ms. Craig, 5 minutes.
Thank you, Mr. Chairman. I'm proud to see that my bipartisan bill, the Live Beneficiaries Act, is included in today's hearing. This bill would prevent Medicaid capitation payments from being issued on behalf of deceased enrollees to Medicare managed care organizations. I want to thank Representative Bilirakis for his partnership on this common sense piece of legislation. I wish we didn't have to put in these types of common sense legislation because it seems so silly. According to a recent HHS Office of Inspector General report, an audit of just 14 states found that more than $249 million in improper Medicaid capitation payments were made to MCOs on behalf of deceased enrollees between 2009 and 2019. Of that, OIG found that over $3.5 million in improper payments were made on behalf of deceased enrollees to MCOs in my home state of Minnesota. That same report noted that CMS is working with states to collect the federal share of these unallowable payments. Mr. Sy, can you tell me a little bit about the initiatives that are currently underway at CMS, such as the reclamation of unallowable payments aimed at reducing wasteful spending and making sure that Medicaid beneficiaries are getting the most out of the program?
Well, I appreciate that question, that focus, especially since we've had much discussion about the need for important home and community-based service investments. Finding efficiencies through good program integrity and fiscal stewardship is very important to us. On the deceased beneficiary piece, and actually you referenced improper payments overall, and we have worked substantially with states to bring those down. I've noted in the past, the vast majority of those are not fraud, they're documentation pieces, but nonetheless, any level of improper payment is unacceptable. For deceased beneficiaries that you referenced, it's an important piece. There are multiple initiatives we have underway. One of those is continuing to reinforce, and as you noted, the audit report notice, we recoup funding when we identify, or an auditor or any auditor identifies that payments of the sort have been made, and so states have a very strong incentive to be able to catch these upfront as early as possible, and we've reinforced how states can use data and also contracts with their managed care plans to help be able to address this sooner upfront versus having to recoup things on the back end.
I appreciate that so much, Mr. Sy. You know, when I came to Congress, I promised I would work across the aisle and look for ways to reform the way government works. This bill in particular makes important reforms to the government's oversight of those tax dollars. By tackling this waste, we can make room to fund other important priorities like the home and community-based services so that many Medicaid beneficiaries rely on. I want to know how we can continue to work together to find the resources and authorities you need to combat more of that waste, fraud, and abuse.
Well, I appreciate that, and I just affirm very much how important that is. We are using every tool in our toolkit to make sure that there's strong program integrity, and we're holding states and health plans accountable. The president's budget has included, in the past also, I believe, something that's been referenced here, the ability for us to be able to have more tools for oversight of managed care plans, whereas today it's an all or nothing thing for financial penalties with states and managed care. To be able to differentiate that level of accountability to whatever the compliance issue is would be a very important tool, and that has been reflected in the president's budget as well.
Well, thank you so much for being here to answer our questions. In closing, I just want to make something very clear. I believe that my colleagues and I have a duty of fiscal responsibility, but unlike a lot of folks here in Washington, I refuse to balance the budget on the backs of our most vulnerable populations by slashing critical health care programs. Our bill is about improving the integrity of Medicaid and ensuring that Congress remains a good steward of taxpayers' hard-earned dollars. And with that, Mr. Chairman, I yield back.
Generally yields back. Now recognize Mr. Crenshaw, 5 minutes.
Thank you, Mr. Chairman. Thank you, Mr. Sy, for being here. Frame this discussion. There's obviously generally a philosophical debate on how states should administer Medicaid. There's a line of thinking that Medicaid should simply be expanded so that there are more people enrolled in it, and in states like mine, there's a more targeted approach, and I think an approach that focuses on access and focuses on making sure that the actual infrastructure of healthcare is better funded so that people who need it actually have a place to go, not just a piece of paper that says they have a place to go. That's an honest disagreement. I think we'll debate that forever. The problem that we have today, and what I want to bring up to you, is that honest disagreement is there, and that would be fine, but now we're in a situation where you are actually targeting states like mine as a result of that disagreement. So as first reported by National Review, records show that CMS targeted Florida, Texas, and Missouri with attempted audits based on a new interpretation of Medicaid financing rules. That interpretation is summarized pretty well in a bulletin that you wrote. It's from February of last year regarding these hold harmless arrangements. Now, that interpretation of financing rules, by the way, those rules that 1115 waiver has been approved over and over and over again. But this new interpretation would cost states like Texas billions of dollars. And it can't help but wonder why, and it seems like it's an attempt to force them to go into Medicaid expansion. And I'm going to introduce that document for the record, that particular bulletin. So, Mr. Tsai, can you explain why did you feel the need to release that new bulletin and on hold harmless arrangements and come up with this new interpretation of what's okay and what's not okay?
Appreciate that question. I think at the core of this, we support two very important things simultaneously. One is making sure that states, including Texas, is able to provide sufficient reimbursement funds for critical safety net providers, and the financing arrangements you're referencing really are funding state-directed payments, which this committee has talked about quite a bit, to support safety net and other providers in Texas. That is incredibly important, full stop. We also have an obligation to make sure we're administering the program consistent with federal law. And on the bulletin you're referencing with the quote-unquote hold harmless, that is not new interpretation from a CMS standpoint. That is our understanding of the statute in 1903, and that is how our team has been focused on that. I would note,
But it would represent a change in CMS policy, because it's, again, this framework has been approved by every other time, and now it's not, or now you're saying it might not.
The informational bulletin represents longstanding CMS policy. The arrangements in Texas are relatively new. The LPPF funding that is of more recent days. But I would note last week, alongside our managed care rules, put out another bulletin that noted that, as we've discussed with a range of states, the three you've referenced and others, it's clear that we stand by our interpretation of the statute, but it's clear that states need some time and data to transition, and we are giving states more time on that.
Okay, but which states, and why only these three states being audited? Because CMS has approved, quote, healthcare-related tax arrangements involving the redistribution of Medicaid payments among providers subject to the tax. I mean, we have this in writing, in emails that were FOIA, that CMS is aware that other states have very similar hospital tax arrangements, California being one, but they're not being audited. So why
It is far more than
did
these
this
three.
stand?
These three came about because there were specific pieces of documents that were sent to and provided to CMS, and our staff has to respond in accordance with their statutory obligations to things sent to us. But the informational bulletin we released last week actually references that it appears that there are a range of states beyond those that you referenced, as you noted, that have these arrangements. And so we've been very clear of what the direction is, and that we are giving all states time to be able to transition, really in support of ensuring there's sufficient payments in your state and other states for safety net
Transition to
providers.
what exactly?
To make sure that the financing arrangements are compliant with our view of federal statute as outlined by Congress.
And what would that, we have 6 seconds, but I would like to follow-up answer on
We'd be
what
happy to
exactly
follow up on that.
would
Thank you.
entail. I yield back.
Mr. Balderson, it's your turn. Is there a Democrat? No. There she is. Who is it? Oh, she's waving on? Okay. Go ahead.
Thank you, Madam Chair. Thank you for being here, Mr. Tsai. I appreciate that. Before I get started on my questions, it's loud. I'd like to express my concerns with H.R. 8115. This bill would allow the federal government to overreach into what has always been the state's responsibility. States and CMS already have plenty of tools to ensure managed care organizations are playing by the rules. I'd like to enter into the record a statement from Medicaid Health Plans of America opposing this legislation and listing out the oversight mechanisms that already exist. Moving on, I want to thank Representative Dingell for her leading our bill to make the Money Follows the Person, or MFP, program permanent. MFP allows nursing home residents to transition to home and community-based services, or HCBS care. Excuse me. One of the most important things we can do to ensure Medicaid beneficiaries have the flexibility to decide what setting for long-term care is best for them, whether that's a nursing home or in their own home. My father stayed in his own home. So this program, which is called Home Choice in Ohio, has allowed 16,000 Ohioans over nearly 20 years to move from a long-term care facility back into their home. The Area Agency on Aging shared a recent story of a woman in my hometown of Zanesville, Ohio, who suffered a car accident. She was homeless when she fractured her leg, and MFP funds helped her to move from a facility to a secure apartment once she's recovered. Mr. Sy, can you briefly speak to how MFP works and why it saves Medicaid money?
I'm so glad you raised that, and thanks for sharing both story for your father and that individual, because that's what this is all about. We want to make sure, as you noted, that people have access to home care, home and community-based services if that's where they choose to want to reside. And that is absolutely critical. And the Money Follows the Person program is, I think, a very strong, proven, and common sense way of doing that. To your question of how does it work, as you've referenced, for an individual in an institutional, say, nursing home setting who actually would like to reside at home, right now, all the dollars are kind of tied up around the nursing home care for that individual. They might not have the supports they need. The Money Follows the Person approach really says, let's take the funding and the approach for having someone in a nursing home, and let's actually use that creatively to make sure we can set them up with the right supports, whether that be home modifications with a ramp or the right home care supports and other things, so that they're actually able to transition into their home or their community.
Okay, thank you. Well, I agree that MFP is very effective. I am worried that new rules finalized under your leadership will minimize the value of this program. The combination of minimum staffing rule and the access rule will force nursing homes to reduce bed counts to meet the required staff ratios, or even worse, close them. At the same time, home care agencies will reduce their availability of care to meet the new 80/20 pass-through requirements. I recently spoke again with a home health provider in Ohio and Indiana who is already facing staffing shortages. They currently serve 315 Ohioans. In just 6 weeks between October and September of 2023, they turned away over 4,600 patients. The CEO even stopped taking a salary in hopes of keeping her company alive. These new requirements will only make things worse. Mr. Sy, how is a program like Money Follows the Person supposed to work if we've reduced the availability of nursing home care and HCBS care?
Well, thank you, then. Please pass my thanks to that CEO for what they're doing to serve our enrollees. Let me just take the home care topic for a minute. And as you noted, there are great home care providers working day to day to make sure care can be provided for folks in the home. We all want to make sure there's access and there's quality of access, and that there's sufficient workforce and staffing for that, and that a sufficient portion, 80% of Medicaid rates for direct care, really should go to direct care workers. But as you noted, we've had many discussions with providers and the industry, and we received a lot of comments during the rulemaking period. The rule we finalized is different from the proposed rule in multiple ways. One, we allow states to have a fair amount of local discretion around some of this, but it allows for exceptions for small providers, others for which the 80/20 might be particularly difficult. Two, it extends the timing out for 6 years, so that 80/20 provision would not go into place until 2030. And third, which I think maybe that's the CEO of your home care would resonate with, anytime I talk to the industry, they say it's not, yes, I want to pay my workers more. It's not just about that, it's also about whether my state agency pays a sufficient rate. And so we have put in multiple things in the rule to really up the ante for what states need to do to make sure there are sufficient rates being paid to the agencies as well.
Okay, thank you very much for your time.
Thank you.
Madam Chair, I yield back.
Thank you, Mr. Balderson, and I now recognize myself for 5 minutes. Thank you for being here, Mr. Sy. You noted earlier that you have data that supports the 80-20 wage pass-through mandate, and the proposed and final rule appears to be absent of this information and analysis. In fact, CMS noted that the number of providers that was used to measure the impact of this rule is based on unpublished provider relief fund data. Can you please be specific on what data was used and the outcome of the impact analysis specific to the percentage of Medicare beneficiaries that will have increased access to home and community-based services?
Sure, I'd be happy to. Thanks for that question. And as we just discussed, our goal here is to make sure there's sufficient, strong workforce to ensure that there is access. For how we arrived at the 80%, I would say a few things. Some of this is in what we published in the final rule as well. There are clear data points that we use to get to the 80% across a number of states. I would also note, and I have to thank this body, Congress, for some of the HCBS funding that the ranking member noted before around from the American Rescue Plan. Almost every state that took up that funding put money into the workforce, and many of the states across the spectrum put in requirements that that guaranteed a certain portion of that funding would go to the direct care workforce. We looked at what states identified to us that they were already doing, thought that was a good idea, and incorporated that into the rule. And perhaps the final thing I would say is the rule also, in addition to pushing out the implementation timeframe, requires there is data reporting in every state so that every provider might know what their baseline point is to start with.
Okay, can you tell me how many direct care workers will have wage increases under your wage mandate requirement?
Well, we want to make sure all direct care workers across the country are adequately and sufficiently paid so that they can provide appropriate care.
So we don't have a number, though, or you don't have a proposed educated guess on the number?
Well, a lot of this would also depend on, again, what we noted, which is states are also obligated to make sure they are able to pay sufficient rates. And so home care, what we've heard from the industry, a fair point is, like I said, it's not just about the 80-20, it's about what my actual rate is. That is a fair point. We included provisions in the rule to really put extra attention to the actual rates that they receive from the state agency as well.
It's like you've had many questions on this because this is a huge topic back home when we go to talk to these providers. Let me ask you briefly about H.R. 8089, the Medicare and Medicaid Fraud Prevention Act. The bill would implement a GAO recommendation to require states to check with the Social Security Administration Death Master File before automatically re-enrolling Medicaid providers. This would also allow states to deactivate the National Provider Identification Numbers, or NPIs, of deceased physicians and providers, and prevent any fraudster from using that deceased provider's NPI to defraud Medicaid or Medicare. Does CMS generally support this proposal, and how would it help strengthen Medicaid program integrity?
Thanks for that. While I can't comment on any specific legislative proposal, I will say we wholeheartedly agree for the integrity of the program. Payments should be efficient. They should be going out to eligible people for eligible services. And we want to make sure states and health plans as well are doing everything in their power, using data
Because
sources
this is
as well.
the provider's NPI that they use if that provider has passed away. And I mean, it's happened at my pharmacy before where, or you can have billed a claim and then the provider passed away and then you didn't get paid for that claim. So, yeah, we need to make sure all that is fair and square here. Let me make sure I've got enough time. Earlier this month, the HHS Office of Inspector General released a report titled "A Lack of Behavioral Health Providers in Medicare and Medicaid Impedes Enrollees' Access to Care," and the state of Tennessee was involved. And overall, the report found there were few behavioral health providers in the selected counties who actively serve Medicare and Medicaid enrollees. These providers represented about 1/3 of the total behavioral health force in the counties, and despite unprecedented demand for behavioral health services, treatment rates in Medicaid and Medicare remained relatively low. I don't know if you and your team have had a chance to review that report, but the OIG makes a number of recommendations for CMS, including taking steps to encourage more behavioral health providers to serve Medicare and Medicaid beneficiaries, explore options to expand Medicare and Medicaid coverage to additional behavioral health providers, and increase monitoring of Medicare and Medicaid enrollees' use of behavioral health services and identify vulnerabilities. Do you agree with those general recommendations, sir?
Thanks. I know time is almost, behavioral health, thank you for mental health, substance use disorder treatment, incredibly important. Oftentimes, access takes too long for Medicaid and other enrollees. We support a whole range of efforts to try to strengthen that. The regulations we finalized last week also put some substantial new requirements in place on that front. We'd be happy to work with your office on that.
Great. I have a lot of ideas. Thank you, sir.
Terrific. Thank you.
I yield back and recognize Ms. Chudowski from Illinois.
Thank you so much. I want to, first of all, let me thank you so much for allowing me to wave onto this committee for something so important and I think devastating. I want to discuss the Medicaid recovery, the estate recovery program. I think it needs to be ended. Medicaid is the only public benefit program that forces the families of a dead person who benefited from home or community-based care to pay from their own pocket and usually from their homes to cover the cost of that care. Families grieving because of the death of their loved one are suddenly hit with a bill that can amount to thousands of dollars. Medicaid is for low-income people, and often their families are often low income as well. The Associated Press has done a big story about it. The New York Times has done a big story. I want to put those two articles, with your permission, into the record. Without objection, if I could put those into the record. Since 2021, in the state of Illinois alone, 17,000 families have lost their homes. One of my constituents who was taking care of her mother in the mother's home was told that she is owed $77,000 now that her mother has died. This program is so cruel. And so what I am asking for is that that this program, and let me ask you the question, I don't understand, this is the only program, and the other thing to note is that the recovery that the states get because they follow the law, whether they like it or not, and some states don't want to do this, go after people's homes and their assets, the return on that has been about less than 1%. It's not working. They aren't getting the money back. And yet families, I have met with people who are absolutely without money because they have been asked and surprised that they were asked to pay for this recovery program. And I want to ask you, what are we going to do about this? This has been all over the biggest newspapers now. What a scandal it is that they go after the family of dead people.
I appreciate you raising that, and I appreciate you highlighting stories of individuals and the impact it has. Certainly when I hear and chat with folks, you hear very powerful, moving stories of the sort you mentioned. I would note, perhaps for this committee, we are tasked with administering the program with states who run their own programs consistent with federal law, the federal law on the books. Federal law requires that in Medicaid there is a state recovery. And so the reason it exists, the reason why we continue to approve states around that and work with states on that is because we are doing so as directed by federal law.
But the people often don't know. States are supposed to inform people, maybe they send them a letter. They don't know that when their poor person dies, and I mean poor, sick, but also poor because they're on Medicaid, they're low income, that they're going to have to come up with thousands of dollars. This is the only program The only helping program that we have in the United States of America that requires this. It is absolutely shocking. And am I over? No. And it just seems to me that this has to be looked at, that the states are supposed to implement it. As I said, many don't even want to do that and want to spend the money going after the money to get reimbursed. How is it that someone on Medicaid, that their family has to come up with the dough when they're dead?
Well, again, I appreciate you raising this and highlighting the impact on individual people and families. We'd be happy to work with your office on this topic. It is very important. As I've noted, we follow the statute that's on the books from a federal standpoint, but we would gladly work with your office on this.
We need to take a look at it. Thank you very much, and with that, I yield back.
Gentlelady yields back. The chair will now recognize the gentleman from Texas, Mr. Pfluger, for 5 minutes for questions.
Thank you, Mr. Chair. And Secretary, thanks, or Mr. Sy, thanks for being here. I'm getting to my first question in your role as Assistant Secretary for Mass Health and Medicaid Director. I believe you submitted a comment letter to CMS's 2019 proposed Medicaid fiscal accountability regulation MFAR rule, which had similar implications for the state financing of Medicaid programs. And in your comment letter, you asked CMS to withdraw its rule, stating its imposition of new state obligations, administrative burdens, and federal overreach. I kind of want to know how you justify your current role in implementing similar policies that you previously condemned as exceeding CMS's statutory authority.
Appreciate that. On the financing and the related topics, as I've noted, we want to make sure there's sufficient funding and reimbursement for states and state-directed payments, which are really important in your state and the state of Texas, and that the financing arrangements are in compliance with federal statute and our understanding of what Congress has required us to do. And that's really how we administer each of those, the financing arrangements that come before CMS.
So in that role and in this role, are there things that have been conflicts of interest that you saw differently from the state level that now you see from the federal level?
No, I don't think so. On this particular topic, again, we want to make sure there's access and support and everyone's following the law, which we can all agree to. And in that particular comment, I think I was referencing some very specific pieces, not around this hold harmless or the financing arrangements, but around other elements of that particular rule. And that is distinct from the issues at play here currently.
It just seemed that comments like that maybe highlighted over-regulatory, burdensome, excessive or unwarranted policy. Do you think that's true? I mean, is that an accurate characterization of what that comment at that point in time represented versus now some of the policies that you're implementing?
I think it's really important, which I think we've demonstrated as this administration, that we are, and I would say this, I know we've gotten a lot of questions around state-directed payments and the growth and what are you doing for program integrity. I think it's important for us to hold two things together at the same time, making sure there's strong fiscal integrity and we're scrutinizing all payment arrangements to make sure they're compliant with federal law, and that's a lot of what is underlying some of that, and that we are supporting adequate funding and reimbursement for the safety net. And in the state of Texas, for example, even as we were having some of these discussions, we continue to approve payments. And I would note, we recently released national guidance to note, hey, we think this is an issue in multiple areas, but we think time is required. We're here to work with states, with providers. We don't want to disrupt the safety net. And we want to basically, we want to also hold true to our fiduciary responsibilities across the program. So holding those two in tension is sometimes quite complex, but it's really important, and we look forward to working with you all on that.
I know this has been discussed. I think my colleague, Mr. Crenshaw, also from Texas, highlighted this. Let me get back into it because I'm last on the panel. It may be duplicative, but how does CMS define hold harmless agreements within the context of Medicaid financing, and what specific criteria are used to identify the impermissible arrangements?
I appreciate that. I would note our position around that is very explicitly outlined in multiple areas, including the informational bulletin that's publicly posted that Representative Crenshaw noted. And we are trying to make sure we both support reimbursement, adequate reimbursement for safety net providers, which we all agree are critical, and we want to make sure that we are administering the program in line with our understanding of federal statute. And Congress has outlined specific statutory requirements in this area.
Lastly, can you clarify the rationale behind the requiring providers to attest they are not engaged in any hold harmless agreements in the Medicaid MCO rule that was finalized last week?
Sure. Again, in line with this balance, that particular provision of the rule, we do not do any interpretation. We just say, is a provider willing to attest that they're able to follow the plain text of the statute? There's no CMS interpretation around that. We can all agree the plain text of the statute is important. But I would also note that in response to public comments, in recognition around how important this is to states like Texas and others, we, in the final rule, we delayed the timing until 2028, and we put out an informational bulletin that noted that we wanted to work with states, with providers, and others with time to resolve these issues, because at the end of the day, as you're noting, these payment sources are critical to safety net providers in your state and many others, and this administration is all about making sure there is sufficient reimbursement and funding available for Medicaid providers.
Thank you. Mr. Chair, my time's expired. Yield back.
Thank you. The gentleman yields back. That appears to be all members appearing to ask questions. Thank you. You've been here for a long day, including the break for votes. Really appreciate your willingness to be here and appreciate your time and the information that we received today. I will ask unanimous consent to insert in the record the documents included on the staff hearing documents list.
It's fine with the minority, Mr. Chairman. If you would just give me 60 seconds or less to close out today.
Well, without objection, it would be in order to accept the list.
Without
Okay.
objection.
Now you're recognized for
Thank you.
60 seconds. We won't start the clock, but
Thank
60
you.
seconds.
I think it's very important to note after listening, and thank the Assistant Secretary for being here to answer all of the questions on both sides of the aisle. We really don't have standards in nursing homes today. 80-20 is new. 80-20 is new, and there's a reason for it. I have an opposite view, as you know, in terms of staffing and the pay. I think it's going to improve. It's going to improve for patients, number one, but it's also going to, I think, improve the business model. 70% of nursing homes today in our country are corporately owned. They wouldn't be in business unless they were making money. I mean, that's their model. It's their model in our country. It's the 30% of others that we need to be careful in terms of the construct. And I think the 80-20, 3 years, 5 years, especially 5 years in rural America, is really very important. So I continue to support what is going to make it better for people. I have to tell, and I've leaned over and said this to you, Mr. Chairman, our former colleague who lost her life, Eddie Bernice Johnson. Eddie Bernice Johnson was the first RN, registered nurse, to be elected to the Congress. She was a first-rate professional. Look at how she died. In a nursing home, healing from surgery. Her wound became infected because there weren't enough people staffing the place. She kept calling out for help. They couldn't come. They didn't have enough people. And they had to rush her to the hospital, operate on her all over again to cut out the infection. We can do better than that in this country. And so I thank you for giving me the time, Mr. Chairman, and it's been a long hearing, but a worthwhile one.
Yeah, I think so as well. So thank you for your words. So I will remind members that they have 10 business days to submit questions for the record, and I ask the witness to respond to the questions promptly. Members submit their questions by the close of business on May 14th. Without objection, hearing none, the subcommittee is adjourned.
Thank you all.